Welcome to 2023 January CFP Distilled. My name is Dr. Simon Moore.
I'm Dr. Paul Dillon. We're here in Vancouver, BC after our sold out course in Las Vegas, ready to come across the country and continue teaching residents.
Exactly. So we got a review course this weekend. We do CCFP exam preparation, but here at CFP Distilled, we take a look at the clinically relevant articles in the CFP Journal from this month. And let's take a look starting with the cover.
Yours is uncovered. I had this super secret rifaximin. We had to tear away that farm advertising and then see, kind of a disappointing start.
Yeah, what is going on here?
I don't know. There's brain, there's vasculature, yet inside there's not a single relevant article about, looks like maybe it's MRIs. That's what they've done. They've sliced someone up like an apple.
Well, I think that does relate to the Parkinsonism and Parkinson's disease, which is the first article that we're going to take a look at. So, diagnostic criteria, you need three things for Parkinson's disease.
Shaky, stiff, and
slow. Slow, shaky, stiff, because I can never remember those big words like tremor and bradykinesia and rigidity. But there's a key point we talk about when we review this at the review course. It's not Parkinson's disease. That's not the 105 topic that you're studying for the exam. It is Parkinsonism. Yeah, so that's why we've got to consider all the other possible causes. And this part one on Parkinsonism really goes into detail about how do we distinguish these. So some other possible causes. We've got a great table here on table one. They talk about, could it be a vascular cause? Could it be multiple system atrophy? And how do you tell those apart? And then we've also got progressive supranuclear palsy. If you've got something like, truncal rigidity, or if you've got extraocular movement changes, then these are ways you can help distinguish, is it Parkinsonism from one of those other diagnoses, maybe from their medications, or perhaps it's from Parkinson's disease.
Let's stick with the elderly and talk about chronic kidney disease in the elderly. What can we do? What are we watching for in these patients? Because they're going to be managed by us in family practice. So a really good quick article that talks about the KIFRI score.
KIFRI score is amazing. It's a calculator. You punch in their score and it tells you what is this person's chance of having kidney disease in the next 5 years.
So it's basically like a Framingham risk score for your little kidneys there. Key numbers to remember is 5% over the next 5 years. So if your KIFRI score comes back with 5 over the next 5 years, you're going to refer them and watch them a little more closely.
Something else to watch closely is you got to do a really close exam if somebody's complaining about anal fissure. You got to get right in there, a lot of stretching involved to move those skin folds out of the way. So if you see that midline fissure, remember if it's not midline, you're thinking something else like Crohn's. But if you see that midline fissure, there are 3 pharmacologic options you need to be aware of. So the first one, the most highly recommended, calcium channel blockers.
What about nitro?
Nitro is another option, but there's a huge side effect. Almost half of people, actually over half of people, 56% are going to get headache. And now there's a third option. This was new to me when I read this article.
Put my hands up, same. Vitamin E, I did not know of this option.
So it's interesting because the number needed to treat for calcium channel blockers is 3, nitro is 4, vitamin E is 5. So what do we do though if the topical treatments fail?
Well, you can use Botox for those bottoms.
Yeah, and the other option to think about always is surgery. Both of those are going to run you the risk of fecal incontinence, not something that you want to be responsible for your patient.
No, you'd want to run from that. Common oncologic emergencies. This is a great article that talks about 3 things that you need to be thinking about or have a high index of suspicion for. Number 1 is going to be spinal cord compression.
Yeah. Another one that you're going to look at is if they've got, it talks about all sorts of things. It talks about hypercalcemia. It talks about febrile neutropenia. So let's talk a bit about the febrile neutropenia.
So for febrile neutropenia, you got a high index of suspicion for these patients who are immunosuppressed. You're going to be looking for the absolute neutrophil count, and you're going to want to be getting antibiotics tailored to them on board right away. The last one, what if I've got spinal,
superior vena cava constriction. Yeah, so these folks, they come in looking like that. Their jugulars are distended. They've got edematous face, and you're starting to think about, could there be a mass in that mediastinum? So phenomenal article, talks about how do you investigate these things, when to suspect them. Make sure you look at the SAMP questions on this that we're going to be sending out in 2024.
Wow, looking forward to another amazing year. For those of you that are interested, we do have a Facebook group where you can ask questions to people who have recently written the exam, for people who will be writing the exam soon. So join that Facebook group if you're interested. We'll put the link up on the screen.
So I'm very excited. We're about to go downstairs and start teaching at the Review Course in Family Medicine, Vancouver 2023. It's not too late to sign up for Calgary or Toronto, or maybe we'll see you in summer 2023 in Toronto. Hope to see you there. I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon.
Welcome to CFP Distilled February 2023. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
So we're taking all of this and condensing it down because we know you're busy. You want to know the basic summary of the most important articles. What are they?
So we're going to start off with an article about nutritional deficiency and dementia.
We're going to talk about Parkinson's pointers for the non-tremor features. We're going to take a look at good SAM opportunities for those.
And at the very end, 2 quick hits on mono and a medication to use or not use. And then a quick hit on some recent updates on menorrhagia treatment.
And so, as we always do, let's start with our cover critique. And so this is, I think, is actually a beautiful painting, better than like the oil drums we saw on some of those other covers. What do we got here?
I think it's actually a challenge for a lot of the rest of Canada. We're from BC. We've got beautiful green grass in February. So it's a bit of a, it's a bit of a challenge for some people to realize where these people are, but they're obviously in BC. Beautiful background or not? What's that in the background?
Yeah, we got a cloud rolling in, which represents dementia. So you want to tell us that story. This is a fascinating case of someone, they thought it was dementia and it wasn't.
So over 90-year-old female, didn't want to go to a care home. She loved to go out and have a chat at her local shop, but all they had there, they had bread, they had crisps, some crackers. That's all she was eating. Ended up having a drop in her MOCA score. Eventually got admitted to a care home and perked right back up. So nutritional deficiency due to food insecurity. So a great reminder in a SU or in a SAMP to ask about everything. Ask about all those social determinants and think about nutritional deficiency in your elderly patients if you see a decline in maybe dementia.
Exactly. Keep that differential diagnosis broad. So let's take a look at Parkinson's disease. Again, people come see us and we're worried about their tremor because that's what we see, but they're more concerned about this symptom list. So what's the first one?
So let's start head to toe. What about depression, anxiety, and sleeplessness?
You got it. So how do we treat depression, anxiety? It's 35% of folks with Parkinson's have it. You know the answer, SSRIs, SNRIs.
So let's move on, keep moving down. What about sialorrhea?
Exactly. Sialorrhea, dysphagia, 2 common situations in people with Parkinson's. For both of them, you can refer to speech language pathology. But when it comes to medications for sialorrhea, what are the options?
So you could use Botox, botulism A injections, chewing gum, or even ipratropium bromide spray. So 3 options for sialorrhea.
Now let's get back up to being backed up. Constipation in people with Parkinson's. Again, you know how to manage it, but make sure you do because 80% of those folks have it.
It is not hard. We're going to go with PEG or...
Did you even mean to make that joke?
I did.
Okay.
It's PEG or lactulo. So no major changes. Your standard approach to constipation, use it in these patients, but just consider it.
You got it. Okay, moving on to another symptom. People with Parkinson's have...
orthostatic hypotension. So what can you do for these patients? You can reduce the antihypertensive they might be on, consider changing their movement, so take a pause when they're doing sit to stand, abdominal binders even in some of these patients. So lots of options.
And last one would make a fantastic SAMP. People with Parkinson's may have restless leg syndrome. What is one condition you want to rule out so you make sure this isn't causing it?
Iron deficiency anemia. And then what are you going to do to treat them? This could be a side effect of the medication they're on. Maybe they're on an antipsychotic. Maybe they're on antidepressants, and that's a side effect. So lots of different ways you can manage this and also offer stretching before bed. Simple
you got it.
management.
And pregabalin, I believe, also mentioned in the article as helping with RLS. So let's change gears a little bit and move on to our last 2 quick pointers. The first one is going to be menorrhagia. Do we use an IUD or an IUS to treat menorrhagia?
So great evidence, good summary. I think this is fairly well known at this stage, but I've seen it in my patients. So an IUS system, better than oral contraceptive, bigger decrease in bleeding, and pretty significant effects re-illustrated in this article. So that's your go-to for patients with menorrhagia, IUS.
Fantastic. And our last article from CFP Distilled, a pediatric population pointer pearl on people with mono, which 90% of us have antibodies to, apparently. So if you got a patient with mono, do we give them prednisone?
The answer is no. For pain, which is what the article specifically addresses, small inconsistent benefits for steroids, but can you name maybe one situation that you might want to consider using it?
Yeah, exactly. Really important to know this. If there is airway compromise, get that swelling down, get those steroids in. Now, there's a couple other complications of mono we need to know about as well. So if their blood count is abnormal, their platelets are going down, you've got thrombocytopenia or autoimmune hemolytic anemia, do we use prednisone in those cases?
So in those cases, yes, it is indicated, but I'd be wanting to talk to specialists and maybe a pediatrician at that stage as well.
We are here in Toronto for our Spring 2023 review course, and we've got fantastic news about our Summer 2023 review course. If you're writing the fall CCFP exam, what is it?
So we're going to be back here in Toronto, great city, but also we've been able to drop the price for the course. So we're super excited to see more and more people attending the course in Toronto near the end of August this year.
So look at thereviewcourse.com/register and find out how you can come to the review course at a lower price than we've been able to offer in a long time. COVID looks like that ship is sailing away, hopefully, and so we hope to see you in Toronto at the review course Summer 2023. Welcome to CFP Distilled March 2023. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
We're going to take the CFP Journal content and distill it down into things you need to know for the CCFP exam and for clinical practice. But first, our usual cover critique. What do you think about this one?
I don't know. It's a bit, I don't know. It's either Botox or chronic pain. I can't tell. Which you can use Botox for certain conditions in chronic pain.
There you go. Yeah, the article is about chronic pain, so definitely you're seeing the light side of that and the dark side of that. This person is suffering. Hopefully we can help them. We're going to talk about some conditions today. We're going to talk about bronchodilators in post-infectious cough.
We're going to pick on from that, and we're going to talk about CNS tumors in kids. What's that red flag? What's the line after which you need to get some imaging?
And then we're going to go with the flow, flozins in CHF. So why don't we start with that? Should you be using the SGLT2 inhibitors in congestive heart failure?
So we have to divide congestive heart failure up into HPFREF.
That's right, HPFREF. Yeah, exactly. So I'm so confused here because I thought that drugs weren't helpful in patients with preserved ejection fraction. Their ejection fraction's over 40%. Why are we giving them medications if it doesn't make them live longer?
So there can be patient-oriented benefits, so less hospitalizations and potentially other ones that'll improve their lifestyle. So that's the positives for those. But how do you sit down and talk to your patients in a really patient-centered way? This article can help with that.
So there's a clinical decision tool you can use at the bedside. You show it to your patient. We'll put that up on the screen for you. You can see it talks about the pros and the cons.
Easy, red and green, something you can sit down at the clinic, at the bedside and talk to your patients about that. Heart failure, you can sometimes have a cough. What we see more often is patients with a post-infectious cough or hic. Tell me a little bit about what you can do to help these patients in a cough that lasts on average 20 days.
I work in family medicine, I work in Indigenous health, I work in urgent care as well, and this is one of the most frustrating things when people come and they say, I've been coughing and coughing and coughing, what can you do for me, doc? And aside from the honey and the lozenges and the saltwater gargle if they got sore throat, like there's really little we can do. So fortunately, there's a little bit of evidence on these puffers. So this one here, the blue puffer, Ventolin, actually not used in this study. They used a different one called Combivent, also known as ipratropium and salbutamol. About 68% of people are going to have improvement with cough at 10 days compared to placebo, about 40%. Now, the other option is going to be inhaled corticosteroids. Again, the benefits of that aren't that fantastic. 60% of people will have improvement at a couple weeks compared to 50% will have improvement at placebo. And that's really the takeaway point, the bottom line. At 3 weeks, most people are going to be much better. You got about 80% of people.
Amazing. So that's a great summary, great article to read for something that's common in family practice. What's our last article about?
So we want to take a closer look at imaging in kids. What is your next step? What is your next step to make sure you're not missing a cancer diagnosis?
So we know from the article that most of the CNS tumors in kids are infratentorial, and these can be notoriously difficult to diagnose because kids are going to come in with maybe a bit of lethargy, maybe a bit of somnolence. It could be a post-viral thing. How do you decide when you need to get imaging? The answer is 4 weeks. Earlier, if you've got some red flags, but at 4 weeks, these kids, if they have persistent symptoms, are going to need imaging. What imaging? Well, CT, because it might be more available.
Not if you're on a SAMP exam. CT is not going to be your first choice.
Great catch, Simon. So CT head or MRI head, which is your gold standard.
Got to list the body part
patients
on the SAMP exams.
So there you have it. And what's a quick, easy way to remember? I looked at this. It says 4 weeks. These are the UK guidelines. This article recommends we use those. 4 weeks, 4 head. So 4 weeks. If those symptoms are ongoing, you're going to need to move on to getting some imaging to find out whether there is a CNS tumor or not in kids.
That's it for the CFP Distilled March 2023. We hope you're looking into signing up for the review course August 2023. We're going to be coming to Toronto and going through all 105 topics in 2 days. For the review course for CFP Distilled, my name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
See you next month. Hi, my name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
Here we are in beautiful Niagara Falls, Ontario, right next to the falls for the SRPC Rural and Remote 2023 conference.
It's a great conference, but we're taking some time out to read through the CFP Journal, and we're going to talk about atrial fibrillation. What are some of those anticoagulation issues you have to deal with when you send a patient to the dentist?
Exactly. We're going to talk about a cause of abdominal pain that you're probably missing in some of your patients.
And last, we're going to close off with some key points on lung cancer. A quick summary article there.
Oh, but first, what do we always do? We start with the cover critique. Let's put that up on the screen and take a look at this month's April 2023 cover. What do you think about this one, Paul?
I don't know. It makes me blue.
Makes you blue. I like that the family docs are the angels, sort of. That's what I see hovering around the patient, the mosaic of the virtual care patient.
Interesting. So there are some other articles in there, not as directly relevant to the exam. So let's dive in and talk about lung cancer first. So it's a crash course in lung cancer. Big definition, delineation is between small cell lung cancer and non-small cell lung cancer. After that, the article goes a little bit too in depth for me for studying for the exam. But what do you need to remember? Guidelines, national guidelines. Not every province has the ability to get those 3 scans annually over 3 years for patients to detect lung cancer ages 50 to 74.
So if my province has a screening program and other provinces don't, then what should I be studying for the exam?
For the exam, you study national guidelines. So keep that in mind when reading any article and any topic.
So let's talk about abdominal pain. There's a great article about abdo pain in adolescents, but this is extrapolatable to adults as well, and they're talking about acnes. So this is anterior cutaneous nerve entrapment sign. So let's talk about diagnosis and let's talk about the treatment as well. So it turns out up to 30% of patients with chronic abdominal pain actually have this diagnosis. You can figure out this diagnosis at the bedside by just doing this. Have you used Carnet's sign?
I have used it fairly often, but I'd love for you to explain it to me.
Yeah, so you ask your patient laying down on the exam table, you ask them to lift their feet in the air, and then you palpate at the lateral border of the rectus abdominis with a hooked finger, and you press on the belly. Same thing is if you get them to flex the abdominal muscles by lifting their head off the bed. And when the muscles are tensed, if you're pushing on their muscles and it hurts more, where's the pain coming from?
The pain is coming from the abdominal wall.
Exactly. But if your muscles are not tense and you're pushing down, you're going to be hitting whatever's underneath there, and then we're suspicious that the pain is coming from
intra-abdominal.
Exactly. So if you're doing right lower quadrant palpation, if the abdominal muscles are flaccid, that's how you can palpate the actual appendix. That's how you can decide maybe the pain is coming from inside. So
it's a great tool. I use it all the time. I've actually added it as a part of my abdominal exam for appendicitis, like you said, just to figure out which layer you're actually testing. Where's that pain coming from? So great test. If you're not using it, start using it.
And that's what the authors advocate too. They say we should all be adding it to our arsenal for every abdo exam. Let's talk quickly about management. These folks don't really respond well to acetaminophen, ibuprofen. So what's your next step for them? You're going to be doing abdominal ultrasound guided injections, usually with lidocaine. If that doesn't work, refer to ped surgery for if they're pediatric patients, and adults refer them to general surgery for they might need a neurectomy. They actually cut the nerve right out.
So let's move on to the final article, atrial fibrillation. What was your takeaway from this one, Simon?
Yeah, so it's amazing that the CCS guidelines in 2020 had a major shift, and a lot of the classic stuff we need to know about the risk factors, management, and as well as thrombosis management as well. And I've got a great tool for that because we're always getting asked to manage that. So, do you want to start with risk factors?
Sure. So what are those big risk factors? There's big 5. There's some lovely graphics in this article, and it talks about those modifiable and then non-modifiable risk factors. That is bread and butter for the exam. So great article to catch up on those.
Exactly. Now, moving on to management, that perennial question, rate control, rhythm control, both are equivalent. So which one are we going to want to start with?
So that's the key point when you're thinking about rate or rhythm, and that controversy is early on, there is a benefit to rhythm control. So early on, benefit, less death, less mortality with early rhythm control. Later on, it might be just the symptoms that you're worried about controlling. So then you can move and shift to the rate control. But throughout all of this, you're still going to have to anticoagulate these patients.
Exactly. And you're going to be getting calls from dentists or from surgeons or anesthesiologists saying, what should we do with this patient's anticoagulation? And it was always frustrating. It was tough to know exactly what to do. But now there's a fantastic pause algorithm. CCS recommends it. Thrombosis Canada recommends it because it's on their website. So let's take a look at that one, and it will ask you the specific question. Is it minor surgery or major surgery? Which are they taking? What are the characteristics of your patients? And it will spit out the answer for you. So that is no longer a pain point in primary care. One last feature from this article is management with rate control. You want to talk about that one?
So there's a great pocket guide that the Canadian Cardiovascular Society puts out. We'll put the link up on the screen. Perfect for family practice, primary care, a good summary of the key points you need to know for management.
That's it for CFP Distilled April 2023. So glad you could join us. We hope to see you at the review course in family medicine. We'll be in Toronto in August, and stay tuned for some exciting destination courses we're going to have in spring 2024. We hope to see you there. Welcome to CFP Distilled May 2023. My name is Dr. Simon Moore.
And I'm Dr. Paul Dill. We're going to be talking about some amazing guideline updates, some key new drugs available in Canada now.
As we do every month, we take a look at the CFP Journal and we take all the clinically relevant articles and distill them down for you. What else do we do?
So we provide those clinical tips and pearls that you might not have time to read, and we give them all to you in a quick format here today.
And what do we do about the exam?
We prep you for the exam, so we filter everything out to let you know what's key for your exam to allow you to nail your SAMPs and SUs.
Phenomenal. First article from this month is about guideline updates. Should you be putting kids on a statin?
Pre-diabetes, pre-hypertension, preschool. Is that when we're starting to screen these kids and poke them and get blood work?
Absolutely. So let's take a closer look at this article. What did they recommend? This is a recommendation from the Pediatric Cardiology Societies, and they're telling us all these kids need to be screened.
Specifically, kids from 2 to 10 need to be checked with those, and particularly looking at kids with a family history of hyperlipidemia. It's high in Canada, 1 in 300.
So we're trying to find who has that because we've got a high incidence and we need to screen everybody. The article recommends universal screening.
But what do you do then with that result? So statins, can you start statins on a 2-year-old?
No.
So the real answer is 8.
8 years
8 years old is when you could potentially start it. So potential game changer. I don't know how this is going to roll out in real practice, but at least you heard it here first.
Taking a look at our next article.
If you've got both chronic kidney disease and type 2 diabetes, who are your best friendia?
Your nephrologist and your endocrinologist.
Other than that, there's a brand new medication, first in class. It rhymes with Ferendia. It's called Kerendia.
Exactly. And the actual medication generic name is finovrelolone.
You know what's great about the exam? You can use trade names. So remember, Kerendia. This is for those patients who have a normal serum potassium and you're looking for a non-steroidal MRA. So new in class, new class, great to know for the exam.
The American Heart Association has invented a new diagnosis when it comes to heart failure.
So what is that new diagnosis? I know we had diabetes, now we have pre-diabetes. I haven't heard of post-diabetes yet.
Well, it turns out the new diagnosis is called pre-heart failure.
So how would you diagnose someone with pre-heart failure?
These are folks who are asymptomatic, they feel fine, but they've got an abnormal lab test.
So they might have a raised BNP.
Turns out we should be treating these folks with 2 medications.
So what are those 2 medications for these people who may have structural disease? They might not be symptomatic, but have a raised BNP.
So you want to have an ACE up your sleeve, start them on an ACE inhibitor as your first option.
What's next after that?
You're going to give them a beta blocker. So that's the A and B for pre-heart failure.
There you have it. New diagnoses, new term. Think about pre-heart failure for the exam and when you're working in your clinic.
Welcome to CFP Distilled June 2023. Every month we take a look at the CFP Journal and we look for the clinically relevant pearls for your practice.
And for the exam, but what do we start with? We start off by looking at the outside cover, and you know what? I think this is my favorite so far. I'm going to give this a 10 out of 10.
I'm actually really impressed. So this is Zachary Logan's queer self-portrait is how he describes it in the description.
It's his face and then this beard that goes out into this beautiful floral bouquet. And we have a floral bouquet of articles and tips and clinical pearls. Let's dive right in.
The first article we want to look at is about anorexia nervosa and a new diagnosis you need to be considering in patients with eating disorders. There are 2 diagnoses you need to know when it comes to eating disorders, and I'm not just talking about anorexia and bulimia.
So what else could it be? Let's talk about anorexia nervosa with one thing missing.
So if you got the diagnostic criteria, you've got those three things you need for the diagnostic criteria. You've got your
Fear
of your body shape. You've got your disordered eating restriction. And you need a third thing, which is loss of weight, abnormal body shape. That's your diagnostic criteria for anorexia.
So what if you have that absence of being underweight? What do we call that? Now, I didn't know this until I read this article.
It's called atypical anorexia nervosa. I'll say it again, atypical anorexia nervosa. Add that to your lexicon. You need to know this one for the exam. It could show up on your next SU.
So what else do we have to think about in these patients? When do you admit them? When are they so sick? What are the things you need to be looking for, Simon?
Bottom line, abnormal vitals, abnormal labs, abnormal findings.
Whoa. You can't just say that on the exam. Remember, we're trying to prep you for exam success. You got to be specific. So you've got to be writing heart rate. You can't just write abnormal vital signs. Be specific about what you're looking for. Could be an abnormality on ECG. Maybe they've got a prolonged QTC. Those are things you're going to look for that are going to lead you to potentially admitting these patients when their illness is more severe.
These are also things you're going to be monitoring for these patients, including blood work. So, for example, the people who wrote this article would probably fail a SAMP on this because they said get CBC and get your lipid profile and get your
electrolytes
and get your liver function tests.
Can't do that. You have to be specific and write the specific indices on the exam.
So for your SAMPs, one answer per line. These are all the things we're going to be monitoring for these folks at every visit: the vital signs, the labs, weight and height, mental health concerns as well.
And what can you do to help these patients, Simon? 2 capstones of treatment.
Exactly. So the first one is going to be renourishment. We want to make sure that we're helping these folks without pushing them into refeeding syndrome.
And the other thing is going to be the cognitive behavioral therapy, psychotherapy. That's the other thing. That's kind of proven. But what's something that's emerging? What other medication could you potentially be using for these patients?
Yeah, there's a lot of research on this. The studies are small, they're conflicting. So some centers are using medication, specifically second-generation antipsychotics.
So consider that as part of your arsenal when you're treating these patients.
It really comes back, though, to the family therapy, getting the family on board. This is what the SU would be all about, is finding those social dynamics and the layers and making sure you're getting them involved in the treatment.
Absolutely essential. There you have it, a great article. You can read it start to finish, but we've summarized the key points for you here today. Let's start with a hard-hitting tip about concussion. When do we get these kids back to school?
So there's an article in the June 2023 CFP Journal, but it also complements the brand new guidelines from Amsterdam introducing the SCAT-6.
Wow, SCAT 4, 5, 6. It's always improving, always changing, and we get the updates at the review course in family medicine. But let's talk about this particular article. What are the things that we really need to start changing when we're treating our concussion patients, specifically about going back to school?
So when it comes to going back to school, we used to say rest. You got to go do that gradual return, make sure your symptoms are gone at the first step, and then maybe in a couple weeks you can be back at school. That is gone.
So what we want to be thinking in the back of our head is we do not want to miss a complete week of school. 24, 48 hours rest, sure, definitely not playing again on the day of injury, but then we got to get these kids back to school. They improve better, even if they're still a little bit symptomatic.
This is going to make a great SU because the parents are going to say, no, they can't go back to school. They keep asking to come home from school. So how do you manage that?
So find a space at the school that they can rest. You don't want them to be coming home. And who's that key person that you could bring in?
Exactly. Every school should have a point person for pediatric concussions. Identify them, say we're going to have a group meeting with them. We're going to conference them in, coming up with a plan for this patient.
That's amazing. So some great tips. We want to get these kids back to school, in school within 24 to 48 hours, even if symptomatic.
This recommendation for pediatric pneumonia feels like malpractice.
What? What are you going to do? Are you going to say give 3 days of antibiotics for simple community-acquired pneumonia?
If the kid's vaccinated, we used to give 10 days and now it's to 5 days, and it turns out 3 days is non-inferior.
This is a challenge, and I think when I go into practice, it's like it feels so weird to write 3 days of amoxicillin. You're like, this isn't going to do anything. But the numbers are actually quite robust.
They've studied thousands of kids. There was big trials with 800 kids in Ireland and UK. There was a meta-analysis with 9 trials showing it's safe and effective. 3 days.
3 days. So this is what I'm doing. If you have the ability to have some follow-up, you know what? Give the 3 days, see them, and you know what? We could be decreasing antimicrobial resistance, less antibiotics for these kids, better outcomes all around. 3, not 10 days. What is that on your arm? Is that what all the cool diabetics have?
Yeah, well, you know, they've all got their continuous blood glucose monitors, and they do that thing with their phone. They go boop, 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 and they're testing their sugar. And I mean, how cool is this? And why don't we just... Okay, it's a gum wrapper package, but I just thought I would see what it's like just for one day.
Highs and lows of being a diabetic. So what are the actual benefits? Now, this is expensive.
Well, it's not that expensive. It's only $6,000 a year.
That's like the cost of one CCFP exam.
Well, how much is it really? Like if you're doing 4 times daily blood glucose monitoring?
It's $1,200 a year.
Okay,
for that.
so big cost difference.
5,000, like you could, I don't know, you could smoke a lot. You could buy cigarettes with that money.
Don't start smoking, kids. Let's not recommend smoking on the CFP Distilled podcast.
Medical. Stop joking, Simon. So what are the actual medical benefits?
It's got to be really useful. Like you wear this monitor, you know exactly what your sugar's doing.
It connects to an app.
Exactly. Less hypoglycemia. Isn't that what's going on?
Less severe hypoglycemia in type 1 diabetics. Isn't that amazing?
Turns out it's actually marginal. So people who have the continuous blood glucose monitor, 6% of them are going to have severe hypoglycemia compared to 8% who don't.
Okay, I mean, I think ultimately patients are going to make their own decisions. A lot of my patients really love the beep, boop, beep. But what about type 2 diabetics?
Type 2 diabetes, isn't it going to lower A1C and have less hypoglycemia?
Yeah. No.
Turns out it doesn't.
No.
Right, so not that great when it comes to the benefits. Lots of people still have them. You go to the pool in the summer, you see lots of people with their continuous blood glucose monitor patches on their arms. People are buying them, people are using them. So it turns out sometimes the patient-oriented benefits aren't great, but the patient still want it.
That's it for the June CFP Journal. Distilled down some key points. We hope you learned something. Hope to see you at our next CFP Distilled podcast or in August at our course live in Toronto.
It is July 2023, and here we are again for another episode of CFP Distilled, where we take the journal and distill it down to what you need to know for your clinical practice.
And what do we start with? We start off with a cover critique. It looks like family practice Jenga. Not a lot of thought or energy went into this cover.
Yeah, I'm gonna. Last month's was amazing, but this month's looks like it was made in like Microsoft Word 95.
I don't know if I would set up foundations of the family practice with Jenga.
Like,
I don't know.
we
It
got a
only
big
falls apart at the end.
Stick of bubble gum on the bottom holding everything up.
I don't know.
This one's just not gonna stick.
There's always hope for next month.
So we're doing a bit of a different format this month for the July CFP Distilled, thanks to your feedback. So we're gonna take a look at this in real time and analyze the articles in a bit longer form.
So let's start. Truth about omega-3s. So this I didn't know. I knew, fish, you're like, oh, it's high in omega-3s. Eat a little bit more fish, get rid of your heart attack risk. But in reality, they come from marine or aquatic microalgae.
Exactly. So the fish are eating the algae, and then we eat the fish, and then our omega-3 levels go up, and we don't have as many heart attacks.
You could try to cut out the middle fish or the middleman.
The thing that blew me away is that a lot of this is really over the top. We don't actually need to be taking omega-3 pills.
Yeah, there's little evidence for primary prevention in CVD. Now, supplementation could be considered in those who have hypertriglyceridemia or who maybe don't eat a lot of fish.
So you got a really small population of people that this is going to benefit.
Yeah, people who don't eat sushi.
You hit the nail on the head there. That's the recommendation for most people. If you want the benefit, eat more fish. 2 servings of oily fish per week is going to be enough for most people.
Oily fish. How do you decide if a fish is oily or not?
Haven't you seen that episode of The Simpsons? You take the food and you smear it on a piece of paper, and then if you can see through it, it's oily enough.
That's like an actual text, isn't it?
Yeah.
I don't know if that's environmentally sensitive, though, to be using.
We'll test that. We'll get back to you on that one.
Okay. In patients who are appropriately like you're on a statin, then do you need omega-3s? No. That's what.
Yeah, and a lot of the studies were done back before statins were done. So that's one of the things I loved about this article is they break the evidence down into the older pre-statin articles and then the newer, more relevant ones.
Okay. Fish oil supplementation can no longer be recommended. Now, here's the other question. If you ever get like dry fish at a restaurant, is that because they took the fish oil out for supplements?
They sucked it out and spit it into a container, put it into capsules.
How do you oil a fish?
How do you oil a fish?
Oil a fish.
Every 5,000 kilometers. So what's the next article you wanted to talk about from the July
The next one is
2023?
reducing the death rattle. I had a patient this morning doing palliative care rounds in the hospital, and he was starting to get a little bit of that death rattle. So these are terminal respiratory secretions.
It's late now. So if you want to stop the death rattle, that's really reactive, and we want to be more proactive is what this article is saying.
So the solution is the prophylactic treatment with scopolamine butyl bromide. So earlier, I think, is the bottom line. Potentially earlier for these patients, dry out those secretions. I mean, it's often more distressing for the family members, I find, than the patients themselves.
It's true. They've considered this really closely and carefully. Does it actually distress the patients? Obviously, it's challenging to do that study, but the theory is you're right. We're treating the family.
Yeah. So it's that holistic care. I think it shows up in SUS, where you got to be thinking about not only the patient that's there, but what's the effect on the family members, everyone who's connected.
It's fascinating if you take a look at how should you prepare for the exam, because you may not be doing obstetrics, gynecology, you may not be doing palliative care, but you still have to know that it's in the 105 topics. So know the common end of life complications. Death rattle is a good one to know.
Now, this one, you mentioned this one to me. I think you texted me about it. You were so excited, and I was like, Simon, let's talk about something else. But
this blew me away.
Why were you so excited you texted me about pyogenic granulomas?
Well, first of all, what better to talk to your friends about than pyogenic granulomas? And secondly, the treatment for pyogenic granuloma is sitting on your kitchen table.
What's on your kitchen table?
Oh, there's a lot of stuff on my kitchen table. We got
pepper?
We got
ketchup, sriracha sauce,
the
sauce on a pyogenic granuloma.
The mess from the kids, the fruit bowl.
Yeah.
With my 2-year-old, he takes a bite out of every apple and then puts them back in the fruit bowl.
Is caring.
Yeah. When it comes to pyogenic granuloma, I'm talking about the salt shaker.
I thought you were treating your hypertension. Shouldn't you not have salt on your table?
We used to cauterize these. We used to excise these perhaps. They bleed a lot. They're really irritating. So
yeah, I mean, I used to excise them, freeze them with like a silver nitrate stick, but you're saying just salt them.
Yeah, so you can make a little bandage island, use your scissors. We'll put up a picture of that on the screen for you. And you can see what you do is you put salt in that little well, in that cavity.
Yeah.
Tape it down for 2 weeks.
That's it. Sprinkled it. I just think it's gonna be weird when you ask your nursing staff to like go to the lunchroom and like give me some salt, and you're salting a patient's finger.
Salting a patient. Honestly, if you're putting salt on a patient in the hospital, I think the nurses are going to start to doubt your competence. They're going to be like, are you like preparing to eat your patient?
Every day, salt application occlusion daily for 14 days. So in the morning, have your breakfast cereal, you have your eggs, bit of salt on the eggs,
Bit
salt
of salt
on
on
the
your
finger,
pyogenic
cover it
granuloma.
over, and that's it. And it's gone.
Yet again, from the CFP Journal, something that feels like malpractice. Last month, we were looking at pneumonia treatment, duration down to 3 days. This month, pyogenic granuloma. Turns out just need to season it a bit more.
Seasoning. Season your patients.
We hope you've enjoyed this new and improved edition of CFP Distilled. Send us your feedback. We love to get those emails. And this is the July 2023 CFP Distilled. Not only do we talk about the clinically relevant pearls, what else do we talk about in CFP Distilled?
We talk about exam tips to get you ready for the SUS and the SAMPs, distill it down to what you need to know for exam success.
So we're really excited to see you in Toronto in August 2023, and tickets are on sale now if you want to come join us in the spring. We got some great cities: Vancouver, Calgary, Montreal, going back to Montreal, and where else are we going?
Las Vegas once again. We had an incredible time last year, a great way to kickstart your studying, be the first person in your program or group to have done a complete review of the 105 topics in January.
Yeah, sign up now while the early bird rate is still on. We'll see you in Vegas.
Boom, another thing you can add to your differential. We're here, August 2023, and we summarize the CFP Journal for you every month. My name is Dr. Paul Dillon.
I'm Dr. Simon Moore. Welcome to CFP Distilled. Whether you're listening on the podcast or watching on YouTube, we are so glad you're here. Where do we always start?
At the cover. So what do you think about this one? It's a bony, it's a hard, I don't know, I kind of like it. It's osteoporotic.
Exactly. Yeah, this looks like a very zoomed in image of a bone structure from the inside of a bone. I guess we're just zooming right into the content.
I saw this actually recently. I was on safari in Tanzania like 48 hours ago, and I saw it must have been an elephant bone, and you could see the trabecula inside the bone. Incredible.
Fantastic. So we got a few articles here. Why don't we start with the clinical review approach to sialinitis? And we are going to start in there. Is this something you see in your practice?
I see it often enough, and I kind of enjoy picking these up because you know it's going to be a quick diagnosis. The treatment is candies or lemon sweets, but I think we should dig around a little bit more. So what are some of the bugs that you might see with acute suppurative sialinitis? Hard to say. It's like, especially if you've got mumps.
So I think one of the biggest ones we need to talk about is Staph aureus, because that's going to be causing all that pus, and that's going to be causing infection. And if you're seeing pus, especially when you're expressing that salivary gland, we're going to think about prescribing. We'll talk about the antibiotics too.
Perfect. And other things that you consider, I did mention mumps. If you're seeing bilateral, you're going to think more about a viral cause.
I like this article as basically the article of 100 SAMs, because they talk about so many possible causes. They talk about there could be the infection, there could be the bacteria, but there could also simply be the stone blocking it.
Yeah, and they may give you a history of stone, so it might be a real easy slam dunk diagnosis, and they've come in just because of that pressure that's there, or it could have a bit of a fluctuation over the course of the day.
So if we see a stone, the next step is going to be imaging, and specifically they want to get an ultrasound. Now, for those of you studying for the SAMs, ultrasound, not going to give you the mark. What do we got to write?
You're going to do an ultrasound, and now what would you say exactly for this one? Would
That's
you say
a good question,
ultrasound salivary gland?
So what does it actually say here? They don't name the body part in the actual article. So I would probably say ultrasound of parotid.
Yeah,
if you're
that's
worried
fair
about
enough.
a parotitis.
Yeah. Yep.
But make sure again when you're writing an ultrasound imaging on the exam, always listing the body part.
And then some of the red flag things to wonder about, like some of the stuff when you're seeing a patient in the emergency room, you're going to wonder, is there an abscess? Has this spread? Is there Ludwig's angina? Has it spread down? Is there any fixation? Is this not acute? Is this something that's been grumbling along? Maybe there's a mass. But once again, you're going to get that ultrasound.
Exactly. So once again, differential diagnosis, stone, infection, mass, or it could be a viral infection as well. So a fantastic article by a medical student out of Queen's University on salivary glands. Now, I also love...
I was going to say medical students love mnemonics, and they came up with a great one for this one, MASH.
You got it. Yeah, so MASH is the mnemonic that we use for management of these. And I always feel like I'm not doing anything for the patient. If it's just a simple infection or simple stone causing parotitis without any infection, sialolithiasis, then what are we going to suggest?
So you can start off with some massage.
There you go. And they actually
yeah.
they describe the technique.
Some candies.
Oh,
Give
yeah.
you some candies.
Okay, maybe,
How's that?
Maybe don't do this for your patient.
Antibiotics into your
the way
and hydration.
The massage technique is very specific.
Oh, because
you got to put your
down.
fingers onto the gland and then you push towards the duct where the saliva is coming out.
Right. Okay. All right. So just getting down.
You mentioned candies. They talk about sugar-free candies.
Important. Yeah, if your patients are diabetic at the same time.
There you go.
Cause some trouble.
2 diagnoses for the price of 1, unfortunately. And also, I like the sugar-free ones, but also the sour ones, like the lemon candies.
Yes, lemon drops.
Yeah, and they get the saliva flowing. And then if you do see pus, we got to talk about antibiotics.
So what would you give for Staph aureus?
Good question. So I think I'm going to go with amoxicillin clavulanate if they're outpatient.
Okay.
But sometimes these people do get really sick.
And then are you going to go with kind of IV ceftriaxone, I'm going to guess?
I think that's a reasonable option. Yeah. The article says ampicillin and sulbactam. So again, not something that everybody's got in their family medicine clinics.
Yeah. Okay.
But when you're studying for the CCFP exam, you got to know those ER options as well.
Absolutely.
That's what family doctors do at the CCFP hospital. And I guess the last question is going to be, look, are these folks getting this for a reason? Is there some sort of autoimmune cause of this?
Sure. Like could it be Sjogren's syndrome? So that's where you really get into asking those questions at the CCFP exam. For those of you that are studying, it's asking those questions. Is this an acute episode? Was there is there anything else? What else would you examine? Do they have dry eyes? Do they have some other rheumatological condition? That's a great point.
Yeah, and just like I said, article of 100 SAMs, another great SAM they could pull out of this is what are the investigations you do if you're worried about Sjogren's. Right here in the article, they talk about the anti-SSA, also known as anti-RO,
anti-RO antibodies. Okay.
We'd be worried about an autoimmune condition. So that's a great roundout of sialolithiasis, sialoadenitis, infection, and salivary gland issues. Which article do you want to talk about next?
I'd really like to talk about the fragility fractures. This is one we were chatting earlier and you caught me out. When sometimes there's different guidelines, but this is actually a good one that really brings together some of the choosing wisely, appropriately treating our patients. So what does this one say? So we know that fragility fractures happen. Where do they happen? Elderly patients.
Usually in the bones, yeah.
In the bones, yeah. Broken heart.
Yeah, exactly.
It doesn't
fractures
happen,
everywhere.
yeah.
Fractured bank account if you're a resident.
Stop. Wrist, hip, spine, and shoulder, common sites in the elderly. But do all of these patients need a BMD, bone mineral density?
So not only do they not all need a BMD, but they don't all even need fracs. And that's what blew me away about this article. So what if you've got a 60-year-old lady comes to talk to you about getting her fragility fracture screening? What do you say to her?
So I would have said yes, but you told me I was wrong. So until they're 65 and female, you're not even going to do a frax.
Yeah, so the CTFPHC recommends against screening females aged 40 to 64 or males of any age. So that's straight word for word from the editor's note. So people who are at highest risk, they're going to come up on the frax. And CFPC Exam loves to get you to list out risk factors from what we've seen on the CFPC's website on their old CFPC questions. So what do we need to know about risk factors for fractures?
Some of the classic ones are high alcohol intake. Are they a smoker? And then chronic glucocorticoid use. That's always one that comes up.
Now, I think that I would want a family doctor to know a little bit more about that. So not just yes or no to steroids, but how much steroids have you used? So is there a dose range?
Ooh, that I don't know. No, but I feel you're asking such a leading question. You're going to know what it is.
Yeah, so they actually say 3 or more months cumulative therapy in the previous year at a prednisone equivalent dose of greater than or equal to 7.5 milligrams a day.
That's a lot of math.
A lot of math, but those it makes sense. Those are the people at highest risk of fracture.
Interesting. Okay. What does it work out to? 90 days. 90
yes.
times 7.5.
A lot.
8.
A lot of steroids.
It's about 1,000. I think it's like less close to 1,000 milligrams.
Yeah, and when it comes to
3 months.
alcohol, what are the numbers? More than 3 units per day, greater than or equal to 3 units per day. Those are the highest risk. Other risk factors, we talk about rheumatoid arthritis, and then those family history, personal history of things that cause osteoporosis. So we've got our type 1 diabetes, osteogenesis imperfecta, chronic liver disease, those kinds of things.
Yeah, chronic malnutrition, that's something, once again, you're going to see in the elderly. When you're thinking about that like cohesive look at the psychosocial aspects of a patient presenting, that's where they're going to ask you questions at the CFPC hospital. Okay.
So those are the folks, the first step of the 2-step process is you should get a frax without a BMD.
Okay, and then what do you do at that stage?
Well, it depends what the patient wants.
Okay.
So I love the little infographic here because they got a picture of a brain and medicine in it. So if they're thinking about pills, well, you don't give the pills yet. You say, you're the ones who qualify for a BMD.
Do a BMD, and then you put it all together, and then you re-estimate the fracture risk with the BMD T-score and the frax, and then you can decide on medications. And then you got to talk to your patients about what are some of the side effects of the medication, how to take the medication appropriately.
All right, so let's move on to the next article here. Let's take a closer look at a case report. I think this one's really cool. The diabetic amyotrophy. So this is a guy who was admitted to hospital.
Okay.
Shows up all of a sudden. Oh, I got severe pain down my leg.
Interesting.
And
One
so
leg.
He's got this severe pain down one leg.
Yeah.
He's got weakness as well. So admitted to hospital. Diabetes is a risk factor. They're thinking stroke. So
Okay.
how would you investigate that?
So, well, I'm sure this guy probably had a CT head, right? Acute, yeah, okay, stroke evaluation. But then stroke evaluation was negative.
Exactly.
But he still got weakness. So there's something weird going on.
So the article is fascinating because they say at this point we should know the diagnosis. I mean, I've never managed or diagnosed this in my clinic, I'll be honest. So it's great that it's in the CFP Journal.
Yeah.
Because it could show up on an exam. And so they actually got an EMG to help sort of the diagnosis.
Okay.
So
that brings up a great point, though, because we don't have EMG at my rural center. We have to refer them out. So it's something to think about is what resources do you have available at the CFPC hospital at the exam? So you have an EMG. Amazing.
Exactly. So you refer for that. You get it back quickly at the CCFP hospital, hopefully.
Yeah.
And then they say there's going to be one of these diagnoses. They all mean the same thing. So many names for the same condition. Diabetic lumbosacral plexopathy, Burns-Garland syndrome, diabetic myelopathy, and diabetic lumbosacral radiculoplexus neuropathy. They're clearly not charging by the word here.
And that's it, because I love these like names, the eponyms, but like Burns-Garland syndrome, I've not heard of that before. Interesting.
So the one thing that they didn't do for the guy in the case, but they suggest, is doing a second MRI of the lumbosacral plexus, trying to find is there a mass there compressing, causing these symptoms.
Okay, fair enough. So that's a good point about keeping your differential broad.
Yeah.
And I think that's what they're going to want to see, is that you do have that thought about what else could be causing this anatomically. That's fair.
So I'm going to put you on the spot here
Yeah.
To try and make a point that suppose this showed up on your SAMS, you didn't know the answer, and it said, how do you manage this case? Or it comes on your SUS. How would you manage this case? And not having read the article, you don't know anything about this, what do? You don't just leave it blank. You put your best foot forward and you say, what do I think would help somebody like this who's got acute weakness, one leg with pain? I bet
I'm
you
gonna-
could come up with the answer.
I'm going to treat the pain.
You got it. Exactly.
I'm going to talk to OT or PT.
Boom, you got
Get
it.
them moving. And then consult. I'm going to consult maybe neurology. I'm going to consult internal medicine, the smarter brains.
Amazing, yeah. And then once you've done that, that's the guideline-based care. That's exactly what's in the article.
Amazing.
Nicely done. And then you're going to end up with usually a good prognosis. Usually it
Okay.
fades away.
Interesting.
And they're going to do much better. So that's a great diagnosis to have in your bag if you've got a sudden acuteness of weakness and pain in a patient with diabetes.
Interesting. That's a great one. That's a great case report. 2 pages. Boom. Another thing you can add to your differential. So let's go on to the last article of this month. How do you stop babies from crying?
I just medicate them. Just give them
Yeah.
as many, like PPI. Isn't that a great option?
Not for infants.
Oh, dear.
So we've known this now. We've seen a couple of articles over the last year about this. About some of the, like the number needed to treat. I think you were saying, Simon, was something like 10?
Number needed to
cause
harm is
Number
10.
needs to harm.
Yeah.
10, that's crazy.
So for every 10 kids that come to you and the parents say, oh, they got a bit of spitting up or they got a
Yeah.
bit of fussiness,
Yeah.
you give them a PPI, 1 in 10 you're going to harm with pretty serious side effect. We're thinking
Yeah, like
things like
respiratory illness, pneumonias. Yeah, so it's challenging. So what happens with these kids? Like you tough it out, and by a year, this is resolved. And what they're gonna have an arching back. They're gonna be crying. They're maybe vomiting, a bit fussy. What are red flags? What would make you worried in a history?
Well, obviously things like vomiting blood or losing weight. But I always remember this story of a doctor named Dr. Jeffrey Blair. He's a pediatric surgeon at BC Children's, and he gave this lecture where at the end of the lecture, he stood up on the table and jumped and yelled at the classroom of medical students and said, "Beware the baby that vomits green." And you know how good of a teacher this guy was? I wasn't even at the lecture and I heard this story. I learned this teaching point because it was such a dramatic
And
story.
now you shared it again.
Yeah,
This guy
so-
is teaching generations of students.
Exactly. So I hope his legacy lives on. I don't think he's actually dead yet, though. So maybe you shouldn't talk about him like he's dead. But he would be very proud to hear that. And
Yeah, so a good summary is basically most kids get better after a year. Don't give PPIs to infants. And watch out, beware the harms. Maybe, pneumonia.
As a parent, you leave the family doctor's office and you're like, they did nothing for me. Like, so
Yeah.
my kids got
Yeah.
regurg and they said, I'm not going to give you PPI. So what
Yeah.
can we do? There's some treatments that we can offer them. So we got smaller,
More frequent
feeds.
feeds, sure. Thickening the feeds, changing up the feeds.
Yeah, I think you put in some actual like infant cereal, mix it in with the feeds.
Okay. I mean, you could bring in a lactation consultant.
I'm pretty sure that it doesn't say lactation consultant. It says an expert who is trained in helping with breastfeeding. There you go. A breastfeeding assessment by trained individuals for breastfed
Is that
I don't know how
not a
the
lactation
I think
consultant?
that's the same
I
thing
think
as a
that's the same
lactation
thing.
consultant.
Okay.
But and then at the very last thing, another key point to remember is maybe we're missing another diagnosis.
Oh, interesting. So cow's milk allergy. So something, to consider. Not as common as I think TikTok might have you believe, but something to consider.
Yeah. So for those
That's
folks,
fair.
you're going to try restricting dairy from the mother's diet. So
Okay.
We know
Short
that
period.
PPIs is not going to help, and so as a bottom line, make sure that you're not harming your infants by giving out PPIs.
Brilliant. Okay, well, so that's a great summary. Some four really good articles actually this month. That's great.
So we are very thrilled to be here live from Winnipeg. We were just here for a family medicine resident retreat and giving you the summary of the CFP August 2023 journal and what else we got coming down the pipeline.
So I can't wait. A new season, new updates across the board. So we've updated all the content and we're going to Las Vegas in January. Can't wait to see the residents that are going to come down. Have a great time and get over the 105 topics in one weekend.
Yeah, check it out at thereviewcourse.com. We hope to see you there. I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon. Until next month.
Take care.
So let's quickly fire through
Talk
these.
faster.
So if you've got multiple cases of diverticulitis, what do? Cut out the bowel?
Yes. Welcome to CFP Distilled September 2023. What do we do every month here?
We summarize all of the important clinical details from the CFP Journal and bring it down to a nice podcast and YouTube video so you can save time and have great success on the exam.
Phenomenal. Thank you for joining us on YouTube or podcast. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
It is great to have you here. So where do we always begin?
At the front cover. So Simon, why don't you have some of your patients at your Indigenous Health Clinic that do some of this beautiful beadwork. This has got to be one of the best ones this year.
This is by far and away I think this is my number one of all time favorite CFP Journal cover.
Okay.
And because I was absolutely struck, I was like, oh, it's beadwork. That's kind of cool. Like,
Yeah,
I see
yeah,
this
yeah.
all the time in my clinic. My staff and colleagues are doing it. I've learned how to do it at my clinic, which is really fun.
Oh.
But then I took a second look, and my mind was actually blown because look at this. You've got a human brain, you've got a set of lungs,
Yeah.
you've got heart, and you've
Heart.
got a stomach.
Wow. Or is that the spleen?
I'm pretty sure it's a stomach. But so I was just like the
And
amount
even
of
lymphatics there?
Yeah, they got
That's
the
impressive.
detail, the resolution.
Yeah.
So this is a Haudenosaunee beading project that was done by Dr. Jamaica Cass. And you didn't know, I'm
impressive.
sure you didn't know, this is actually 24 karat gold-plated beads.
Wow.
As well as Swarovski crystals. Isn't that amazing?
No way.
Yeah.
Really?
So
Wow.
I think this
Okay.
is the best cover of CFP Journal
Art and medicine together.
of all time. I'm
So-
sorry. Usually the cover critique doesn't take
Yeah.
half the podcast, but
So
I'm
tell me,
so impressed.
if you were making this, it's a dangerous beating with all those crystals and stuff.
Mm-hmm. Yeah, the crystals.
What if you had some sort of nail trauma?
Oh, that's a great point. Yeah, you stab yourself with the needle, or you
So-
drop a bead on your finger.
Crystal nail trauma.
So let's make this topic crystal clear.
Ooh, nice. God.
So our first article is on nail trauma. What do you want to tell me
So
about
let's say you do have that nail trauma. Key aspects of your physical exam. Number one is going to be the neurovascular exam. So you're going to check for cap refill, make sure that's all good. Assess 2-point discrimination. Fair. Does that always happen in the emergency room? Probably not. Evaluate full range of motion. Absolutely, you've got to do that. And then this is something that I think I probably made this mistake early on in my career. Putting a tourniquet on during your exam. It just gives you a beautiful, clear, bloodless, essentially.
Don't
field
forget
of
the
view.
tourniquet.
Yeah, don't forget the tourniquet.
Amazing.
Get it on, do your examination, and do your repair with it on as well. Makes a huge difference.
Love that. Yeah, I know when I call the plastic surgeons, I always try and lead off with age, occupation, and handedness.
Yes,
and that's sure enough,
absolutely.
in the plastic surgeons who wrote this article, they say that's a huge part of that. Key points for SAMs or SUs, you want to ask about risk factors such as?
Risk factors for which? For poor healing? So
You
are they
got it.
diabetic? Is that
Yeah.
where you're walking me to? Or
If they smoke
are they
cigarettes,
smokers? Yeah.
when was
Yep.
the last tetanus vaccine?
Yep, 100%. So key low-hanging fruit, absolutely. So different forms of nail injury. So you're doing your beading project. Did you drop something on there? Was there another piece of trauma? Is there an underlying fracture is essentially what I think they're trying to get at.
Yeah, and the really cool thing about if there is a fracture, one of the ways to splint that, one of the ways to help with the regrowth, is to actually sew the nail back in place. Or if you don't have the original nail,
Yeah.
then you actually put a piece of foil from the suture kit back in place. Have you done that before?
I've done that once before. I tend to, if the nail is still there, get it off, clean it off, make sure there's no actual injury to the nail bed, repair that, and then put it back. I tend to use Dermabond over suturing it back in.
I know I found it actually really interesting that they didn't mention the evidence on that because they've done some research on Dermabond.
Yeah.
And cosmetically, you can't tell the difference with the outcome.
Yeah, I find patients are happier about it.
Yeah, and the key factor here that I would say a plastic surgeon told me, a pearl, we see a lot of these in urgent care as well where I work, do not use removable suture if you're going to sew that nail or even a nail bed. Because
Yeah.
you absolutely do not want to have this person coming back to clinic
Yep.
and then you're trying to cut out a suture. No, so always use absorbable suture, always use a tourniquet, some great pearls about nail injuries.
Some great images as well.
Yeah, they're pretty graphic. I don't know if we're going
Love
to put
me a
those in
good
the
trauma.
YouTube version of this. Where to now?
So the one, let's hold off on 1 second, and this is one of the most fun things ever, but subungual hematomas.
Oh yeah, exactly. So I found it fascinating. They actually referenced some evidence on this.
Yeah. And so what does it say? Like, I really love the idea of grabbing, and I talk, like sometimes in really rural areas, there's no little bovie, and you're like, I just get a paper clip and just light it up and make it red hot and pierce the nail. Patients get that relief from that throbbing pain. And after you've seen it a few times, you recognize these people come in holding their finger, and it is a throbbing pain, but that trephination deals with it.
I used to like doing that too, but there's also a couple other ways to do it. So one is to use like a heat cautery pen, like a Bovie
Yep,
electric
yep.
cautery, try and melt it. But I found patients get panicked by that. So
Yeah,
now
yeah.
I just use like an 18 gauge needle and use it like a little drill. Just like
Spin.
you get your fine
Yeah.
motor skills and make
I
sure
like
get-
you actually put the syringe onto it, and it gives you a bit more of a
yeah.
handle to hold.
That's fantastic.
Yeah.
So a lot of practical pearls from a great article by a plastic surgery resident and a medical student from Calgary. Where to next? ABCs of vitamin.
D. So vitamin D out, in,
Yeah, this
helpful?
is a choosing wisely article. So that's your big hint. What do you think they're going
You're
to
gonna
say?
stop doing everything.
exactly.
Yeah. Don't do medicine anymore.
Don't test for
Stop
it.
everything. Yeah.
And I actually like this article because it's really based in reality. And they talk about, okay, patients are going to come and they're going to ask for it. So how do we approach that?
So number one, we don't want to be testing levels So that's going to save something like $30 million a year. That's crazy money. It's enough to hire one plastic surgeon.
Exactly.
So save a huge amount of testing. You're saying don't test in northern areas of Canada. Yes, you can give supplementation, but no real benefit kind of in the rest of the country.
Yeah, and so they talk about the approach, maybe ask them why they want the test or treatment, and they've got a really great algorithm on what do you do if they say, I still want it. Then you say, inform them, and you show them the tool. And if they say, I don't want it anymore, then there you go. You've saved the system some money.
Yeah, it's really outcome-based. And I don't think the guidelines, we say like how many units of vitamin D, I think 1,000 international units a day. I think we'll probably see an update in the guidelines probably in the next 2 or 3 years. But until that time, it's really good Choosing Wisely article. Once again, telling us, don't do it.
You got it. Let's take a look at naltrexone bupropion for weight loss. Is this the sexiest drug on the market for weight loss right now? Definitely not.
No. So now we have these injectables, but I still have a lot of patients that are just against that idea of a needle or an injection. So why is this article important?
Yeah, so you do need to know the first lines. You need to know that you've got the GLP-1 agonists. There's a new GIP coming down the pipeline as well very soon. But some people don't want injections, and so we've got to think about pill form.
Pill form. Okay, so that's fair enough. So second line, know your second line for the exam, naltrexone bupropion.
It actually is a little bit cheaper than your injectables. It does work to a degree. I mean, so half the people in the study, they got 5% or greater weight loss compared to only about 20% with placebo.
Okay, and then some side effects still with that ends up being kind of constipation, nausea. Those are the big ones, I think.
Yep, exactly. So keep that on your back burner as a second line if you're on a SU and some patient says, I really want to lose weight, and you start with the lifestyle, and then you explore their reasons, and then they don't want the injectables. You got this in your back pocket.
Beauty.
Moving on to our final article. Now, this one has got a smattering of recommendations, and they're not slow recommendations, are they?
No, they're not slow. Are they fast?
Yes, that's the title, is Rapid Recommendations.
Okay, so let's quickly fire through these.
Talk faster.
So if you've got multiple cases of diverticulitis, what do? Cut out the bowel?
Yes.
Oh, God, my God.
Yes.
That was an interesting one, the gut update. Elective surgery to prevent recurrent diverticulitis should be considered for patients with persistent, so over 3 months, and recurrent over 3 or more episodes in 2 years of complicated diverticulitis. A little bit of common sense, I guess, coming to that one, but I don't know. I wouldn't be offering it to patients on the first visit, but maybe for some patients, a bit of surgery might help instead of antibiotics. But we also know some of the new guidelines for mild, uncomplicated. Maybe there's some early NSAIDs could help.
Yeah, exactly. So they've got specific numbers here. More than 3 months or 3 or more episodes in 2 years. I had a patient this week in my clinic who she went through exactly that process. She had 3 episodes, and then she saw a surgeon, and they did the resection.
Did they? Interesting. Okay. What are some other quick hits? So this is an interesting new one. So we've seen this change from like med school to residency to now in practice. What are we doing for initial C. diff infection, Simon?
Yeah, it totally depends on what stage of training. In med school, the first line was metronidazole.
Metronidazole. Med school, metronidazole.
Yeah. And
residency switch to?
2018, the IDSA guidelines came out, and it was just a game changer. They said vancomycin oral is your first line. Because remember, oral is not absorbed, and so you take that orally, it's not going to get absorbed other than the gut. It's going to do a great job for C. diff there.
Yeah, and I saw that change in my hospital. Everyone was bang on vancomycin. That's what people are getting, I think 2-3 weeks ago, same thing. And now this comes out. So what's happening?
It's outdated now. So IDSA, once again, I don't know if they're in bed with Big Pharma, we didn't check the disclosures here, but they're now recommending the most expensive treatment. They say it's because the resistance is climbing.
Yeah, fidaxomicin, so narrow therapeutic window. They now have that as number one. Now, I haven't seen it in my formulary yet at my hospital, so it'll be interesting to see, now that this guideline is there, are we going to see it rolled out more, and is it going to be covered? Or are we going to see an article shortly that's going to say vancomycin is just as good on a cost-benefit analysis?
Yeah, so if it's not severe, and if vancomycin or fidaxomicin are not available, Flagyl is still on the table as an option.
Back to med school, still works.
Let's wrap up with a final Canadian recommendation, because that last one was from the IDSA from America. So the Canadian Association of Hospital Dentists has a recommendation for those folks who come see us. They want antibiotics for their dental infection.
I'm thinking back to the beginning of COVID, and is this the first in-person meeting that the Canadian Association of Dentists have had since they did that big outbreak that started off?
That was at a Vancouver.
It was a
conference,
Vancouver conference center, yeah. So what they're saying is they're saying no antibiotics for a simple dental abscess.
Yeah, so
but we see
didn't-
this all the time, don't we?
It didn't add any benefit. Yeah, I actually had a patient get sent in by a dentist
Yeah.
because the oral antibiotics had failed, and they got sent in for more antibiotics.
Are dentists going to follow their own guidelines?
I guess we'll have to find out. I mean,
Does this guideline have any teeth?
this this is one of the hardest things when you're trying to explain to a patient that that amoxicillin is not going to take your dental pain away, and a million times they've had it before, and a million times it's worked.
Yeah, I don't know. I think we're going to get a big seesaw of like patients are going to come to the ER or see you in the clinic and they're going to say, I need some antibiotics. The dentist won't see me until I've had some antibiotics. And maybe they just need some NSAIDs. I don't know.
You got it. So that's a fantastic summary of the CFP Journal for September 2023. Did I mention how much I love the cover?
Amazing.
Such a good
Frame
cover.
it.
Those of you on the podcast, you do need to download a picture of this amazing cover. So it is such a privilege to be here in Winnipeg. We got invited to speak to the family medicine residents at the resident retreat. And a lot of them have told us they're going to be coming to the review course.
Yeah, from the center of Canada. We passed by the very center of Canada and we're going to be going to Vancouver, Calgary, Toronto, Montreal, and Las Vegas.
Hope to see you there. I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon. Until next month.
It's basically the exact opposite of the Canadian Cardiovascular Society guidelines. Everything is different. So treat it. Welcome to CFP Distilled October 2023.
We're here live from Family Medicine Forum in Montreal.
My name is Dr. Simon Moore,
And I'm Dr. Paul Dillon.
and every month we go through the CFP Journal and find the most clinically relevant articles for your practice or the CCFP exam. But first,
Let's start with the cover. I think this is kind of unique. Now, I initially saw these hexagons and N's and C's and H's and O's, and I was like, oh, this is the Krebs cycle.
I thought so too, but in the description it explains what we're actually looking at is a family doctor walking through a statin molecule, something we do every day in our
And
clinic.
he's following the lines on an ECG.
Well, that brings us
Complex.
coincidentally into our first article, which is about the new guidelines.
So it's talking about when are we going to give statins, how often are we going to test, what are some changes from these simplified guidelines. So if you had to say one thing, Simon, what would you say about this peer guideline?
It's basically the exact opposite of the Canadian Cardiovascular Society guidelines. Everything is different. So treat to target,
No,
it's out, yeah. CCS guidelines say recheck, sometimes even every year if people are high risk. And how often should we recheck people's cholesterol levels?
so this is game changing in some ways from what I see in certain practices and even what I've done for some of my patients. And I think having this guideline actually helps in decreasing that repeat testing when you're not going to change manage it. Patient on a statin, you've made that decision 10 years before you test it again, or maybe 5 in certain
Exactly, yeah.
other
So
cases.
they got a wonderful flow chart. We'll put that up on the screen showing the flow chart, and it shows you exactly how in primary prevention often to check. And if they're low risk, it says every 5 to 10 years.
5 to 10 years. So that's great. So less testing, less resource intensive, both from a financial standpoint and on our patients. And a great thing on that same form in the corner is a QR code with a great risk calculator that they've done as well.
A couple of other things that are fantastic here. All those word salad testing that the cardiologists are doing, we don't recommend them. There's not enough evidence for them.
Yeah, so that's your lipoprotein A, the ApoB, and CAC, coronary calcium scores. It's not recommending those. Now, I think in practice patterns might differ a little bit in different places. You might still be doing it, but as a family doctor, we're not using those to risk score our patients.
Yeah, if you see a cardiologist ordering a coronary calcium score, maybe the patient's asymptomatic, 10 to 20% Framingham risk or cardiovascular risk, and they're over 40 years old, your cardiologist might order it. Don't feel guilty if you're not ordering them for your patients. The evidence isn't really there
We're
yet.
not using them as screening tests is the bottom line.
Exactly. One final point from this article, what if your patient has muscle pain after a statin? It actually addresses that in the guideline.
So yeah, things have been different with this. People have tried to change statins or say stop statins. What would you do according to this article?
Well, we know that people on a statin are going to have muscle pain about the same as compared to people with placebo.
It was
We've
like
seen that.
14%, I think, was the study. It showed
Exactly, yeah.
14% for each.
About the same. So it says if your patient stopped because their muscles hurt, re-challenge them.
Re-challenge them. go for another run.
Yeah, and I can think of some particular patients who are particularly re-challenging in clinic that I would want to help them out, reducing the cardiovascular risk, if you get my drift.
So yeah, so statin re-challenge, those are the two key words. And then we're gonna remember as well that 5 to 10 years. So that's, you're gonna have some just difficult discussions with some patients who are gonna come in and say, aren't we checking my cholesterol again? I used to do it every year. You'd say you don't need to, you're on the treatment already.
Exactly. And one final note about why are these guidelines so different from the CCS?
Which you're gonna tell me?
No, I'm not going to disclose that because of my disclosures. Isn't there some big deal about disclosures? So a lot of the people who are on the CCS guidelines have pharmaceutical disclosures, but to be an author on these simplified guidelines.
Yeah. We met some of them today that were involved in this guideline, and I really like them. Lots of different provincial colleges are involved in this. I think Alberta, OCFP as well. So really great guidelines. I love the stuff that they put out.
Exactly. So 2 thumbs up for the Peer Simplified Lipid Guidelines.
Amazing. So let's continue on and talk about the next article, which is cancer-related lymphedema. And a key medication point we're going to talk about in this one for lymphedema from this versus, say, fluid buildup.
Yeah, so the diagnosis in this is typically very straightforward. It says that right in the article. But we're family doctors. We've got to think about the other possible causes.
So other causes could be trauma, could be obesity, the patient could be overweight, chronic venous insufficiency, I see this fairly often. Could there be a DVT? Could there be an acute diagnosis as well? But what about specifically if we say, yes, we know this is, say, breast cancer related, which I believe is the #1 kind of cause for lymphedema. So you're gonna get it in the upper limbs. Some great images in the article as well that show the different stages from 1 to 3.
Yeah, so there's 2 phases of management. So what are those 2 phases of management?
So we're gonna start off by getting that volume. So moving the volume off, and then you move into maintenance. So 2 fairly distinct phases where you're trying to acutely get it down and then keep it off.
Yeah, so this one blew my mind. Diuretics?
No.
We do not use diuretics in that initial volume reduction phase for treating cancer-related lymphedema.
Yeah, and it comes back to basic physiology, the stuff that you didn't do well in med school.
Thanks a lot, yeah.
But so what do we actually do for volume reduction phase? And this can take 2 to 6 weeks, so a great piece of advice to the patient. This is not gonna be quick like Lasix in 6 hours. So compression therapy, you're gonna start with weight management, physical activity, and that would be 2 different lines if you were writing the exam. Skincare, reduce risk of cellulitis, and then what's that final point of what not to do?
Do not give diuretics. So, a fantastic article and really, really useful tool to facilitate your compression therapy prescription. We'll put that up on the screen as well. Love it when these clinical articles have got practical pearls for my practice.
Beautiful. So let's continue on, dive into, this is one of the interesting ones, and I'm gonna have to do a deeper dive into the research on this one, but a flu shot that prevents death after MIs.
Absolutely, yeah. So this is the second time it's come up in the CFP Journal this year, but we found that if you give somebody a flu shot, that golden window, 30 days after an MI, what happens?
What happens? You could save 2 people from cardiovascular events and 2 people from dying at 1 year versus placebo.
Exactly. So
maybe vaccines are good.
Maybe they could be good.
Side effects from vaccines.
That's why we're giving away a ribbon to put on people's FMF name badges at our booth that we got this custom printed. It says, vaccines cause
A
adults.
horrible side effect of vaccines, adulthood.
So yeah, really useful study. They talk about meta-analyses where this evidence is quite apparent over thousands of patients. We know that you're going to save lives if you give people the flu shot after they've had an MI.
That's all straight from Family Medicine Forum. Come by the booth if you're here. If not, hopefully we'll see you next year. And if not, we'll see you next month on the next edition of CFP Distilled.
We're going to talk about the atopic dermatitis treatments other than steroids.
You've been watching Oppenheimer too many times.
Welcome to CFP Distilled November 2023.
I'm Dr. Paul Dillon.
I'm Dr. Simon Moore. In this video, we are going to go through all of the practice-relevant articles in this month's CFP Journal.
So what are we going to go through? We're going to start off with some referred autalgia,
That's
or
fantastic.
are we going to do something right before that?
Yeah, why don't we start with breast density notification?
And then we'll move on to some myths about screening, and then straight into tools for practice. What's going to happen in tools for practice?
We're going to talk about the atopic dermatitis treatments other than steroids.
You've been watching Oppenheimer too many times. And finally, we're going to do Praxis Rapid Recommendation. So Danielle O'Toole's finest work.
Fantastic, and it's part 3. I know a lot of you have been waiting for those 2022 guidelines. We have them for you now at the end of 2023. And there is a great article on thoughtful prescribing for patients with difficult to treat depression, new nomenclature. But first, as we always do, where do we begin, Paul?
At the cover, and we have a beautiful cover, simple. It's November, so the poppy, great symbol from in Flanders Field.
You know, I told you there was going to be no curveballs like last month's podcast, but here's a curveball. I'm actually biased. I love this cover because I actually know Dr. Andrew Seal. And
Who
he
is Dr. Andrew Seal?
He is a plastic surgeon. Well, let me just put it this way. There are two kinds of people in this world. People who apply for awards and people who have awards named after them. And so he started Spring Gala at UBC Medicine. He is a incredible humanitarian, incredible plastic surgeon, incredible teacher. I'm starting to digress. So you get the picture, and
So,
that is
so stop digressing and start regressing into the table of contents and the cover.
of
So what do you
beautiful
think?
poppies. Yeah,
So this is a surgeon who is doing an artistry course of some kind, and I think some people have said you can't be a good surgeon and a good artist. So
well, if you look at his Instagram, he's got a whole beautiful
does he?
panorama of his home studio. So
wow.
I guess that's what happens when you retire.
no, it's stunning, simple, but beautiful, with a great Canadian history with John McCrane in Flanders Fields, represented by the poppy.
And very significant meaning to that as well in November, as we always hold dear. Why don't we dive into the first article about breast density, and family doctors are getting notified about this. So what's next?
So this was interesting for me because often in my practice I would see BI-RADS 1, 2, and I repeat that back to the patients and verbatim almost read off what radiology recommended for next screening. But what does this article answer about patients who have increased breast density?
Exactly. So there's going to be a lot of questions that patients are going to have. They're going to say, why did the report say that I've got extremely dense breast tissue?
So it's because there are glandular issues, it's the actual density of the breast, but the clinical implications to that patient are the important part. And they separate it out in simple quartiles. So less than 25% fatty dense tissue is A. The small cancers are more easily seen. What's the problem with more dense breasts, over 75%?
It's going to be much harder to screen for those cancers. So there's some really practical tips in this article that I think we should be aware of when patients come and ask us about these.
So number one, you can talk to the patients about modifying the density of breast tissue. I don't know how valid this is going to be in real clinical life, but modifiable factors are smoking, postmenopausal, obesity, and a sedentary lifestyle.
There's even hormone exposure, if they're taking contraception,
Sure.
Or even diet
Certain
may
diet
play a
things.
role. They didn't get into the granular of what you say to a patient for specific diet modifications, though.
So what am I going to be worried about in a patient who I've got some radiology back that shows they have more dense breasts? I'm going to be a little bit more worried if something changes. So that's not a great recommendation, but it's going to just peak. It's going to set off maybe not a red alarm bell, maybe a pink alarm bell.
So I think part of the message in this article too is patients need to be familiar with the density of their breasts, and if they are at higher density, maybe be a little bit more vigilant when it comes to them.
Yeah, so a great piece of information to give to your patients when you're using this shared decision making around doing any imaging.
And if you're getting deep into this, if you've got a focused practice, you're seeing a lot of these patients, there is a specific tool, the IBIS tool, which was a new one to me.
I'm going to have to go back to that
And
one. IBIS. Is
that's
that a
right, yeah.
European? No, Egyptian.
Yeah, it's
The
basically
IBIS stork.
IBIS? Oh, okay. Yeah, you're trying to test my Greek mythology, which is
Yeah.
quite weak. Like the throne of Dioclames. I just make stuff up
Is
when
it?
I don't know.
I can't remember it. I won't remember it. The
IBIS.
slide at the review course.
Oh, yes.
In family medicine on breast
So that's
cancer
one I do know
screening.
about
Which,
Artemis.
Who's that?
Oh my
Artemis,
gosh,
that's
it
right,
actually comes
it
together.
is.
Okay, so Artemis is the Greek god. you're just going to embarrass me afterwards and mock me for knowing this, but Artemis is the Greek god of fertility, and you may see this person depicted with multiple, like dozens and dozens of breasts. Thanks for letting me shine on that one. That's
Artemis.
amazing. Thank
You are my Artemis. Let's move on to our next
I
item.
got
Whoa,
one liner.
What else?
Ibis tool predicts your risk of breast cancer. So it is basically like the Framingham of breast tissue.
Wow. It's a Framingham for everything. I'm sure there's more. There's more material, but let's keep going.
Okay.
Keep going.
There is more material, so let's keep
First,
flipping
are we going
pages.
to talk about the adverts we see in here?
No, we can't talk about ads.
We can't talk about this drug that's going to show up in a future article.
Yeah, if we start talking about drug ads, it's going to keep us awake all night.
Ooh.
Wink, wink, insomnia
I have
drug.
insomnia.
Hey-oh.
Whoa. There's a whole load of 4 classes. Are there 4 classes? I think there's. What are the 4 classes of anti-insomnia?
Oh, we're actually going to do this. We're
Yeah,
reading
well,
through
what
the-
would you,
the
we're not,
ad?
I'm not reading an ad. I'm reading educational information from
let's
an
just
ad.
tuck it in amongst the articles, so it looks educational.
Well, it looks very educational.
Oh,
It's more
interesting.
colorful than the rest
Actually,
of
you
the
know what?
journal.
If I was studying for the CCFP exam, this is a totally
It
fair
actually is.
question.
It's a really nice.
What are the 4 classes
Yeah.
of insomnia medications?
So benzodiazepines, but you shouldn't be using them in the elderly. Choosing.
yeah, that's
choosing
what the
wisely
ad
and
says.
safely.
You
Yeah,
shouldn't
yeah.
use them because it's not an ad for
So what about the
benzodiazepines.
Z drugs
Yeah,
that
those
put you
are
to
your-
sleep?
those
Is
are your-
that why they're called Z drugs?
Well, because they all start with Z. Zopiclone,
Yeah.
Zolpidem, and S Zopiclone.
Zopiclone,
They all have
yeah.
an S in them. All right, and then the
Z-
third class.
Z. Doxepin, which is a non-selective monoamine reuptake inhibitor.
And then the final class is the orexin receptor antagonist. Interesting. You know, if I was studying for the exam,
Yeah.
should we be focusing on new things to practice?
Sure,
that are-
it's approved in Canada.
Yeah,
They
relevant
have a
to
bigger
family
marketing budget than all of the other insomnia drugs with their nice color.
Phenomenal.
Without naming a specific one.
No, not a single specific drug was named or listed as better than any other ones.
And for those people who wanted to go into internal medicine, on the facing page of the article,
Yeah.
you can go into the mechanisms of action.
Because yeah, patients always ask me about the drug's mechanism of
Yeah.
action. But in all seriousness, though, some of these drugs do have a suspect safety profile that actually hasn't been convincingly proven, and so that's the downside of the
Which
medication.
one is that?
Well,
Is
it
that-
doesn't say in the ad. If you
shocking.
look at tools for practice, they've got a great article on that. It's in one of the updated slides for the review course for spring 2024, and they talk about the downsides of some of these drugs, which again doesn't make it to the drug company ads.
That was the 3rd page of the article. They couldn't afford it for the
Yeah.
advert. So let's move on. Referred otalgia.
Yeah, so basically this is like any otalgia Paul sees because he refers it.
ENT.
Yeah,
Let's
exactly.
follow up with your family
Every
doctor.
otalgia. So this article by a bunch of ENTs in Calgary is basically begging Paul, please stop
Yeah.
referring all of your otalgias. In fact, a lot of them aren't related to the ear.
Amazing. So what are the editor's key points? I think they wrote this one just for you. A complete examination of the head and neck should be
You're not going to
performed.
start massaging my face again like the last episode, are you?
Oh.
And the submandibular massage? Okay, let's just
So
skip that
what are the
part.
parts? Palpation of the neck, examination of the oral cavity, oropharynx, anterior rhinoscopy. Are you doing that routinely, Simon, following the...
I actually do. So in all seriousness,
okay.
yeah.
Yeah.
I'll take the otoscope and you put a ear speculum on it, and you don't
Yeah.
tell the patient it's a speculum. Then it's a really awkward moment if you do. And then you basically flip the end of their nose up towards the sky, put the ear speculum up there, and you tell
Yeah.
the patient, you warn them, don't take a breath when you're doing this, otherwise you're going to fog up my lens.
Oh, that's a great practice tip. Okay, interesting.
So the ENTs say we should be doing that, and we should, document that in your referral letters, show them that you've done everything.
It is
you can.
easy. You can see kind of larger polyps in older patients who are worried about cancer, for example. But let's get back to the article.
Well, that is the point, because the ear actually is the source of pain in less than half of otalgia cases. So we should be looking for cancers is one of the main messages.
Interesting. I had not heard of that before.
So other places we're looking at dental problems.
Oh, come on.
Heard, okay. Yeah, clearly that one went right over my head and in
wait,
one ear and out the other.
How many kids do you have?
How many?
3?
I've got 3. Yeah,
How many
so
dad
there'll be
jokes can you fit inside a dad joke?
3,000. What? Oh, is there
I
one
don't
for
know.
that?
Dadception.
That's. Nice.
Okay, let's get back to it. So referred otalgia. So you have to think, are there dental issues?
Mm-hmm.
I mean, that's not something I always run to, but yeah, definitely have a look. Sometimes patients just might have kind of a rotten tooth up there, some dental caries,
Yeah,
and they're getting
they
some
say,
referred pain.
My ear hurts. Head and neck malignancy. So again, pop SAMP question, what are your risk factors for head and neck malignancy? What are red flags on history and exam? What they're going to talk about.
So dysphonia, it could have voice changes maybe. We've seen these patients come in with their change in voice, dysphagia, difficulty swallowing. This one for me is a worrisome thing. Progressive, and then bam, something made it a little bit worse potentially.
They don't come until it's stuck though.
Yeah.
They often don't. Odynophagia is really important to distinguish from dysphagia because it's not stuck swallowing, it's painful swallowing.
Yeah. Subtle but important difference, especially when you're talking to your ENT colleagues. And dyspnea, shortness of breath, a new neck mass.
I guess that's pretty obvious.
Yeah, it's fairly obvious. It's like after Christmas time. Oh, what did you get for Christmas? A new
that's
neck
like
mass.
the McMaster answer to that question.
Is it?
Yeah.
How'd they answer questions?
Well, they only get
differently?
3 years of med school in McMaster, right? So, what is a risk factor for head tumor? If you can see a head tumor.
Interesting.
All
Yeah.
right, great. Now that we've alienated 1/7 of our Ontario listeners.
3 years for med school and then a 3-year family medicine residency.
No, it's not 3
6
years.
years. What?
Due to the advocacy of someone else.
Did that happen in November?
Yeah.
Maybe that's going to happen in the future.
Speaking of digressing, did you hear about that one? Okay. So what else do we need to do? We look in the nose, we look in the throat, we ask about risk factors. You know what's really interesting though is because there's a lot of common innervation. The trigeminal nerve is going to serve for innervation of not just the ear, but also inside the mouth. That's why it all makes
Interesting.
sense.
I wouldn't have always thought that. Yep. Okay, fair enough. Oral mucosal lesions. And the interesting one I thought at the end, they finish off with it, but cervical spine pathology.
Yeah. You know, funny of you to just breeze over all of TMJ disorders, which, you know...
I work in the ER, Simon. This is coming straight back to you from me.
Yeah, see your family doctor for this, who's going to refer you to ENT, who's going to reject the referral. Because there's actually...
And you'll end up
back in the ER. Yeah, it's the cycle. The cycle of TMJ life, which is really unfortunate for these patients. It's really frustrating for them because it's hard to get a diagnosis, a management. But, you know, I have seen a lot of these folks try and seek care and no one really gives them the first steps of treatment. So what would those be?
So mainstay of treatments is conservative therapy.
Yeah,
For the what's the type of joint? Giglio arthroidal joint.
Okay.
That's the TMJ joint.
Oh, wow.
It's the only one that slides and
Okay.
is an elbow in the whole body. Isn't that wild?
Okay.
Such a unique joint. Causes lots of
so
problems.
much Greek today. This is
Yeah.
amazing. Gonna need some. Gonna need to use a translation app to make it through the next CFP Distilled podcast. So we manage those folks with massage, warm compresses, and non-steroidal anti-inflammatory drugs.
That's what I would see in the ER for some of these patients. I would at least give them a trial of ketorolac to start with maybe, or some naproxen or ibuprofen at lowest possible doses for the shortest amount of time. Maybe PPI cover, but just see, especially if they haven't done it yet, can sometimes sort them out.
Yeah, and I think we can wrap this up with just a couple of last diagnoses. You mentioned cervical spine, you mentioned physiotherapy to those patients. And then what kinds of infections cause people to come in with ear pain?
So sinusitis would be the one that would be top of mind. And you can see this sometimes, and especially if it's unilateral.
Yeah.
Ear pain is bilateral, talgia would be something different. But if it's unilateral and they've got a bit of a temperature, maybe low-grade fever, maybe a sniffly nose, think about sinusitis.
I think one of the most interesting ear pains I ever saw in residency was a lady who came in and she had burning and stinging pain, hypersensitivity to touch, and we diagnosed her with herpes zoster sine herpet, which now we're moving into Latin, which means without the herpetic lesions.
Yeah.
And sure enough, a couple days later, she came back with the rash I predicted she'd have. I felt so clever.
But then she had the rash, so your diagnosis is incorrect.
It was herpes zoster sine herpet.
Yeah, but you said she had it afterwards.
Well, that's the prodrome of it.
Oh, okay.
Are you on my side here, or what's going on?
Unilateral? Which side are you on?
Oh,
That's a zoster joke.
Hey!
But I think,
Okay.
yeah,
We
interesting.
need to stop reading
I mean,
each other's minds.
The other interesting ear pain I've heard about is insects in ears. So check
I've
for
seen this
insects.
too.
Have you? Did you drown it with lidocaine?
The bug was already dead. The patient said, "I feel like there's a bug in my ear," and I was like, "Yeah, sure." And there was a bug in his ear. I couldn't.
I love
believe
that
it.
when the patients are right.
Yeah.
You just have to believe your patients.
All right, now let's do this one in French. Altalgia referee.
Referee. That's someone getting in between, like
Yeah, I'll
battling
give you a
ears.
red card if we keep going on that one. So.
So hold
Doctor
on.
joke.
Let's give some red cards to myths about screening.
That's good.
Let's do this one quickly.
Okay.
What are some myths about screening? And this
No, there's
myth
no
one,
myths
earlier
about screening.
detection results in better outcomes. No, screening saves lives.
But what about
No.
that 3
Did you just
Tesla,
say no?
4 Tesla, 2,000 Tesla MRI
new
machine.
technology, more benefits. There's got to be better. It's a new screening test. So
Gotta be
what's
better.
the reality? Page
gonna
700.
save lives, isn't it?
Save page 770. So we talked about, maybe no isn't the right word. Maybe there's some nuance here. So newer is better. Newer tests, everyone thinks they're going to be positive, may detect more disease, but you got to have some longer term studies in terms of screening.
More is better. Is that a myth as well?
Detecting more disease is not a synonym of benefit. So balances between benefits and harms, false positives, false negatives, those all have to be taken into consideration. What about screening saves lives? That sounds great to me.
Yeah, it saves lives, but there's also harm in screening as well. And then there's specific things that come into play with this as well. Disease-specific mortality, and people think that there's a perception of benefit from that. But at the end of the day, you need an absolute estimate of benefit as well as harm, and that needs to be transparent for the patients. My favorite anecdote about this is the patient who, just got a stress test to make sure their heart was okay, and it was a little bit ambiguous, so they got a cath just to make sure their heart was okay, and it was perfectly clear, but the patient had a stroke on the cath table. And so here you go. They just thought it was great to screen, but there can be realistic harms. We need to move into the mindsets of our patients.
Yeah. Brilliant. So let's move into the mindsets of our patients who may have atopic dermatitis.
Atopic dermatitis. This is going to be the pronunciation conundrum because we got our.
So what do we recommend to these patients? So
steroids.
Number one, no, short daily baths.
Slather
now, I don't
piles
know.
of steroids on their face and folds.
No. Short daily baths, soap-free cleansers, and fragrance-free emollient twice daily. Now, what do you do if there's no bathtub?
Steroids.
This doesn't count for showers versus baths.
Oh, interesting.
I just had a patient who said they couldn't get their kids into the bath because they live in a home that doesn't have a bath. So.
Okay. Hot tub, is that mentioned in here?
No.
Number of jets. See, this research is flawed.
It's flawed.
I used to think that Tools for Practice was high quality research, but they're not naming the number of jets per tub for actually helping these patients.
So it's Tools for Practice, good, quick, simple updates. What does this one say in the end about using some of these new calcineurin inhibitors versus steroids?
Yeah, so we all know steroids have got those downsides, and on your SAMPs you're going to be aware of, thinning of the skin, scarring, telangiectasia, permanent damage, and so your patient's going to say, but I've got it on my face, so what can I use instead?
What are the other options? So you could use tacrolimus is one, or pimecrolimus.
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 Another
rolls
option.
off the tongue, doesn't it? So those are two options, and what this article ultimately is saying, they're basically equivalent. Tacrolimus might be better than
Pimecrolimus.
Yeah. But steroids are good enough. But that key consideration you mentioned about the SAMPs, what are some higher risk areas where you may consider a calcineurin inhibitor? And these are probably pretty cheap, aren't they?
Oh my gosh, yeah. So you're going to be paying 10 times the price for these fancy ones. Now, I remember there was
Tesla of creams. That could be like a Tesla edition.
There you go.
Tacrolimus.
Costs 10 times as much. It goes about 1/10 the distance.
Yeah.
Amazing.
Like it. Nice.
So I remember there's a big hoorah hubbub about these drugs because people said, if you rub them on your skin, it can cause lymphoma.
Oh, I don't remember hearing.
So that black box warning was actually removed by Health Canada in 2021. They said, look, there might have been a little bit of signals on the research, but not enough to actually leave it on the label. But wrapping up, there's one huge side effect you've got to warn your patients because half of your patients using these calcineurin inhibitors are going to complain of this side effect.
To be burning skin.
Exactly.
My skin is burning. I think it lessens with time, but something to obviously talk to your patients about, save them a return visit, set expectations.
Now, something that's been burning on my mind since 2022 was Danielle O'Toole's been sending out these rapid recommendations. I don't know if taking 2 years to get to print is that rapid, but after all, this is part 3 of the 2022 rapid recommendations. A couple guidelines to know, a couple that actually jumped out at us, really, really vital to know.
The SOGC updating its risk factors for pre-eclampsia and preventative therapy with ASA.
Yeah, so
that was a big takeaway, I think, in 2022.
Oh my gosh, totally different than what I learned in my training. So we need to be prescribing ASA for patients who are high risk for preeclampsia.
And so who are these patients with risk factors? So two of the big ones include obesity and assisted reproductive therapy.
Yeah, take special note of those. Those are the new ones that came out in this guideline. So that's why it's so important.
And then what else is there? Risk factors for so what are some high risk ones?
You know, if they've had preeclampsia before.
Oh, easy. That's a quick mark on the stamp, but this big long list. What else? ART we mentioned, pre-gestational diabetes, chronic kidney disease, SLE, or antiphospholipid antibody syndrome. That's 2 answers on one line.
Yeah, well,
Can't do that on the exam.
That'd be wrong on a stamp. You've got to have 1 answer per line. For those of you who use memory tricks to remember these things, if you just think about the kidneys, you know that's going to be your hypertension, your kidney disease.
That's a great way to remember
your lupus. It's going to lump those 3 for you. So if you have any one of those, you should be taking ASA between 16 and 36 weeks.
Discontinuing. Yep. So boom, 16. So for 20 weeks of your pregnancy, you get an ASA. There's a couple.
Sorry, starting before 16 weeks and discontinuing by 36 weeks. And I think it's a good note to mention about the dose too.
So it's interesting. They talk about 162 milligrams. So 2 of them would maximize the efficacy, but the lower dose would maximize safety.
Yeah.
So if your patient is higher risk, I'd probably like to run this by an obstetrician. But if your patient's higher risk and you're comfortable, you're going to be giving 2 of the baby aspirins a day. 2 babies for the future baby.
Twin dosing and higher dose for higher risk. And then if you've got any 2 of the moderate risk factors, so your patient is pregnant, they've had an abruption, stillbirth, reduced fetal growth rate, there's a few more here. If they got any 2 of these, what else?
What else? Multifetal pregnancy or nulliparity, so first baby.
Or if they are over 40 years of age, those are the folks who were thinking 2 of those problems, then let's give you some ASA.
I think we should move on and get a couple of these others. Some of them are U.S. based. U.S. Preventive Services Task Force recommends screening children 8 to 18 for anxiety and 12 to 18 for depression.
Sorry, what? Teenagers get anxiety?
Yeah.
Wow,
and
that's
now
a great recommendation.
I don't know. I think this is a U.S. recommendation.
Amazing. They just noticed that in America.
Yeah.
Hey, okay.
And then if you don't have the resources to give these people, I don't know if there's actually going to be a benefit there.
Okay.
Next one. Ooh. Had you heard of this society before?
You've never heard of the World Federations of Societies of Biological Psychiatry?
Yeah, so it's not even just the World Federation Society of Biology, it's the Society of Societies.
Oh my gosh, that sounds high level.
Very high level. And they partnered with...
Did the Canadian Network for Mood and Anxiety Treatments join in? Oh my gosh, they did.
What do they call these things where like a restaurant and pop in? Collab.
A collab.
This is a collab.
Oh, it's like a beer that's brewed by 2 breweries.
Yes, exactly. Except it's 2 societies that got together.
Amazing.
Just make a new guideline.
And these recommendations basically look like the supplement section of my local pharmacy.
It looks like a great Indian recipe. I think you can make a good turkey, right? St. John's wort, saffron, curcumin, lavender. That'll make it. Some specialized oils and zinc. Oh, and even ashwagandha. That is a depression curry.
That sounds delicious. That's amazing. Nothing brings me more joy than a good curry.
Good cooking, but so I don't know. This made it into the top recommendations. It's all weak recommendations for different adjuncts.
Okay.
They even I don't know if we should spend too much time on that, but this one.
Well, you know where this is actually really clinically relevant for me, though?
Is
because patients come to me, they say, well, I don't really want a medication for my depression.
Oh, interesting.
And then the second I say, well, let's talk about the supplements that have been proven to work in depression. Like seeing their whole tone and body language change. Like,
interesting.
This doctor's not like dismissing me outright.
But how do you sell a weak recommendation?
At a high price? Speaking of
I
drug
understand
ads.
where you're getting at. That's a great way to use this information to maybe, get the patient to make some other choices. Great point. What about this one? What are you going to have with your curcumin and saffron
So
in the evening? What are you going to have as your drink?
Another quote from the Department of Obvious Recommendation Guidelines. Less alcohol is invariably better.
That was not a fun guideline committee, to be honest.
I did not.
Imagine that. You're at the end of the hard day of building guidelines. You're like, oh man, hey, you want to go for a run?
Yeah. You're sipping a whiskey, reading your CFP Distilled, and it says less alcohol is better. So this was an enormous splash in the media. And so we're talking, of course, about the Canadian Centre on Substance Use and Addiction, new Canadian recommendations on alcohol intake. And what were they?
So it's patients who consume 2 or fewer standard drinks of alcohol per week are likely to avoid alcohol-related consequences. Broad all-encompassing term. And the media, I think, spun this a little bit irresponsibly, like drinking irresponsibly. And I think it actually just makes that broader point. Everybody is different. Everybody's going to be unique. You're going to have different life circumstances, but overall, less is better. I think that's a fair enough message. I think if they distill it down to that, we'll actually see some patient-centered benefits from this.
Okay. They do have another couple of cutoffs and numbers to know about. So specifically, they say, if you drink 3 to 6 alcoholic drinks a week, then you are getting an increased risk of cancer.
That's fair.
And then more than 7 a week, that is your cutoff for increased risk of cardiovascular disease.
Okay. Now, if I'm sitting there as a patient, I'm getting that information. It's still a little bit too broad. I think if you just tell a patient you're going to get some sort of cancer, I don't know if that's going to change.
Yeah, I agree. I think saying
communication
less
is going to be
better.
Yeah.
Patients won't like it, but that's what the research says.
Yeah, but I'm seeing more and more patients who are coming in who are trying the alternate 0% drinks.
Yeah, it's amazing seeing the ads for that. I mean, maybe
Local
Facebook just thinks
supermarket.
I've got a problem, but they say, there's lots of ads for alcohol-free cocktails. You see this in restaurants now. For those of you who don't have 3 kids and can make it out, but there's a lot more have alcohol-free cocktail menus.
Okay, we are almost at the end. I think this is the last article and maybe the most important one.
Yeah, I think this is the one about resistant depression.
Is it? Whoa! Is that
right.
what you
There's
call
been
it?
A nomenclature change.
Ooh.
So I really found this interesting as well. That the term now is not resistant depression. What are we calling it now?
Difficult to treat depression.
So that really
DTTD.
reflects changes in terminology in the field for various reasons. I just remember making slides for the review course. We got over 100 updates this year in our new course, and one of them is about the new naming for what used to be fatty liver disease. And a lot of that was initiated by patient advocacy groups. So now that's called metabolic associated steatotic liver disease.
So we're going to see more and more renaming over the next couple of years. So what about this specific one? So these are patients that are common to emergency rooms, family practices across the country. Patients who you've started them on an antidepressant, maybe you've given them 6 to 8 weeks, not working. What do you do? And you have to remember, a lot of the studies are only based on 6 to 9 weeks response rate. So that's what I find in common clinical practice. A time to reassess, is that dose working for patients?
So I really like how they talk about the 4 different medications that we can consider switching people to, adding on an adjunctive medication. So these are add-on medications for people who have already tried an antidepressant. Maybe they've already switched from the antidepressants. So what's your usual go-to? I mean, the drug companies really want you to start with antipsychotics.
Yeah, I don't think that's very common in family practice. If you're getting to this level with these patients, they're more than likely going to have seen, they'll be off the wait list, the 18-month wait list for psychiatry, and they'll have been seen once perhaps. Most common in practice, I would see mirtazapine and bupropion.
Okay.
Antipsychotics and lithium as adjuncts, I don't think that many family doctors are just going straight to that without at least trying to reach psychiatry.
So that's a really neat thing about this article, is it really gives you some guidance on not only should I switch medication or should I add medication, a great table on that, but they actually go into great detail about people with difficult to treat depression. What medication should we use? In what types of patients would we find this beneficial?
So I thought this was a great article because at this stage, you've been working with these patients probably for at least a year, if not 2 years, if not 3. Maybe you've known them for longer. And there are some benefits. These patients may have comorbidities.
So quetiapine can lead to weight gain. But
it's got better if dealing with comorbid anxiety or insomnia.
Yeah, so backwards. I would honestly, let's be honest, in real life, in clinical practice, I would not be memorizing this table. But I would look it up. I'd pull this really useful table 3 out and show it to patients and do a bit of that shared decision making. And it's worth it. As we wrap up, I do want to share an anecdote of a patient I saw just a few blocks from where we're recording in beautiful Vancouver. She was I tried her on her, I was doing a locum for a long-term 9th, 10th, 11th, and ultimately 12th antidepressant medication. And clearly I should have tried some augmentative therapy, which I think she'd done, didn't work. But I remember it was actually the 12th drug that it was worked. Like a light switch for her. Yeah.
Oh, wow.
Her husband came into the clinic and he brought me this enormous bottle of Yellowtail, like a magnum of Yellowtail wine. And he was just overjoyed. And I'll never forget what he said to me. He's like, Dr. Moore, I have my wife back.
Oh, that's lovely.
Yeah, it was amazing.
That's a lovely note to finish up this month's extended CFP Distilled. Some great highlights, great pearls, and we'll see you guys next month.
We'll take care, and we look forward to seeing you at CFP Distilled in December 2023. See ya.
Start at the bottom,
Okay.
and I'm gonna work it to the top like Drake.
Okay.
So this one.
It's a modern day reference that I don't get. So. It is December. Oh, were you starting? Okay, let's get started.
You go first.
Oh, that's so kind of you.
I went first last time.
Is that your Christmas gift to me?
It is.
It is December 2023. We are very excited to look at CFP Distilled once again in this video. What do we do like every month?
We're gonna summarize the clinically important articles and give you key exam tips.
Amazing. So let's dive into the table of contents. Which articles are we going to focus on today?
We're gonna talk about the CTS guidelines once again, strategies and considerations for patients with mild asthma.
So most of our patients with
Again,
asthma,
this is like
it's
the
mild.
fourth article this year on this.
Amazing. And the next one is going to be about supraventricular tachycardia.
Yeah, this is an important one. We don't see it all the time, but what are we looking for on physical exam, and what are the patient's parents going to tell us? What's next?
Bronchiolitis in infants, again, very timely this time of year.
So all kid stuff so far. SVT in kids, bronchiolitis in infants, patients with mild asthma. What are we going to finish with?
The last one is going to be about your patient has a high triglyceride level. We'll talk a little bit about a lawsuit in this area, what you need to know about one of their major risks. But first, every month, we do our cover critique.
Cover critique. So what do we have here? This is someone who has just learned about collage
Yes.
for the first time.
It looks like a collage of collages.
collage.
We've got our happy face, the drama, really,
Shakespearean, different sides of the brain is I think what they're trying to get
it's
at
like
here.
medicine, there's drama, it's like my brain.
It's the first AI generated image that was ever made.
Could be, yeah. So what was the actual point? This was illustrated by Michael Fong, and it's called The Struggle Within. So actually, maybe it did meet the artist's purpose.
I struggled to interpret it, to be honest.
There we go.
So
All right.
that was my struggle within.
Well, clearly we're here to talk about the science and not the art. Okay.
So what about the edit? And now, just pause for a second before we get into the
Oh,
article.
you
I
right?
think
You really wanted to do this, hey?
The best edit of the year. This gets it for the award for the best title of editorial.
That's right. So Nicholas Pimlott.
Nicholas Pimlott, You Can't Eat Scenery. And now I get it. He goes into it as a movie and it's Scottish.
Why
and
would you
a
dispute
Russian
that?
fishing boat captain in the story, but
Why would you argue
you
that?
can't eat scenery.
Can you eat scenery?
If you're at a floral display, it's
If
in
you
the
live
background.
in a vegetable garden. Okay.
Peter Rabbit, you can eat all his scenery.
Well, I'm going to write a letter to the editorial and explain that, yes, you can eat scenery
Eat
if
scenery.
you're a resident.
If you're Peter Rabbit.
All right, so
you're a
let's
resident.
carry on and take a look at the first, flipping a lot
First
to
article,
get.
So you got to get to 829.
Yeah,
and so
why-
I've done something different.
Yeah,
I've
why is
done
it
something
so
totally
thin?
different. What I did is I tore out all of the advertising at the back, thick, desperate need for family physicians. And it's a much lighter, more efficient, aerodynamic, some might say, CFP Distilled. Like comparing
Wow.
mine to yours.
It's like the CFP pamphlet.
See, you can weigh it in grams.
There's very few clinically relevant articles that month.
It's a light. It was Christmas. They checked out early.
Okay, fair enough.
They're gone.
But they said, let's go with the big heavy hitters, asthma. But let's focus on mild asthma,
Mild asthma.
which is actually pretty clinically relevant. So the guidelines came out in 2019, and they had a huge change to asthma treatment for mild asthma.
So that was adding in the steroids, wasn't it?
Yeah, so the Global Initiative for Asthma said, let's use steroids for everybody with asthma, no matter how serious. In 2021, the Canadian Thoracic Society said, let's rethink this and focus on high-risk patients.
So who are high-risk patients? How do you separate them out from medium, low, high, well-controlled asthma criteria? Now, this is something, I'll put my hands up, I don't always do this. I have my set of questions I ask to figure out, is this patient high risk or not? This is nice because it codifies it.
Yeah, so we've got two great tables here. Who's at risk for severe exacerbation and who's well-controlled. They actually say, if you ask patients, most patients in the 90th percentile are going to say, yeah, I'm well-controlled. But that's because a lot of them are using their short-acting beta agonists all the time. So
Yeah.
what should we be asking them, Paul?
So you'd want to ask them, frequency or value of daytime symptoms, nighttime symptoms, and are they having symptoms with physical activity?
And then this one I find really interesting because there's no real qualifier other than what the patient thinks. You say, how severe are your exacerbations? And if they say severe, then it's defined as severe. And if they say it's mild, then it's mild. And of course, mild and infrequent, that's your marker for well-controlled asthma.
So this one was interesting. Sputum eosinophils. Do you ask your patients to self-assess that as well?
Do you not look at sputum eosinophils in your office? Where's your microscope, Paul? My goodness. So one of the most common questions we get at the review course, because we focus on the eosinophil count, and I love how people are this detailed because that's how SAMP question writers think. They're focused on what kind of eosinophil count. Is it a blood eosinophil count or is it a sputum eosinophil count? And in this case, you're right, it is sputum.
Eosinophil. So this is something I may start to order. I don't know if I'm going to order it all the time. I think by looking at, 6 of these, I don't know if that's going to be the game changer for me.
I know in our COPD lecture, we talk in this 2024 updates of the review course, we talk about how sputum eosinophils is really going to change the direction of which medications you're choosing in diagnoses like COPD and asthma.
Interesting.
So which ones of these folks are going to end up in hospital?
So assessing risk of severe exacerbation. So which are you really going to be worried about? Number 4, current smokers. So you've obviously failed in your smoking cessation. Well, I just think it's one that you might brush over as a part of the overall picture of the patient, but bang, if they're active smokers, they are at high risk, severe risk for exacerbation.
There you go. Your number 1 cause is your number 4 cause in the table. So what else makes me think this patient's probably going to end up in ER with a severe asthma exacerbation? And what do you know? Number 1 is they've had a severe asthma exacerbation.
Yeah. But that's one of my basic questions. Have you ever been admitted to hospital? Have you ever been intubated before? Instantly higher risk. And that's one of the first questions I ask when they come into the emergency room. And if they can't answer that because they're so short of breath, that's a bit of a problem. But so the number 3, I'm going to work up this list opposite from you. I'm going to start at the bottom, and I'm going to work it to the top like Drake.
Okay.
For this one.
That's a modern day reference that I don't get. So.
So overuse of SABA, and the definition they use for overuse of SABA is more than 2 of the blue inhalers a year.
Yeah, have you filled 2 prescriptions or more? No, more
2
than 2
inhalers.
prescriptions.
Yeah,
more than
2
2 inhalers.
inhalers.
I'm on my 3rd one. You are likely to get an exacerbation that is severe.
So yeah, so I think a lot of patients would use more. And so if you go back and if you can see their pharmaceutical history, bang, they're increased at severe risk. So so smoking and more than 2.
And then just to bring it right back to the beginning, they're high risk for severe exacerbation if they are not well controlled. And that goes back to that first list that we reviewed. Really, really great pointers for a SAMP. Bottom line, really the point of this article, maybe we should be thinking if they're higher risk, giving them steroids.
Yeah.
Now, why do you think, Paul, that these authors might be interested in increasing the pharmacotherapy of our patients, especially if, the number needed to treat is like 40 or 50?
That's really interesting. That was a really leading question. I could almost tell because I've known you so long that you have some sort of a insight or secret answer to this.
Funny, when you go to the disclosures, there is, the authors do have pharmaceutical funding. And so I find it quite interesting that they overlook the controversy on this guideline, especially because there's in the American Family Physician Journal, they've got an article about how the pharmaceutical funding, if you follow the money, has really helped influence this as a recommendation. So I'll get the tinfoil hat out for that one.
Do you think maybe after they do the mild asthma committee, so it's CTS guidelines committee just for mild asthma, do they get promoted to like moderate risk?
I think they get promoted to the spicy asthma committee. Mild, medium, or spicy. That's how I take my chicken wings, and that's how I take my asthma recommendations.
Asthma to chicken wings. Okay, let's bring it back to something more relevant.
This is a super topic, I gotta say.
Let's move quickly through this one.
Very quickly. We're talking about acute supraventricular tachycardia, but before we do that, I do notice there's an ad for the world's second best CFP podcast. That's right. You told me not to talk about it. But
there it is. Sarah Fraser. Yeah. She came to our talk at Family Medicine Forum.
She came to the CFP Distilled.
She said she listens to us, but she's a podcaster.
Exactly. Yeah.
She listens to us, and now I want her to send us an email if she's actually listening to this.
Did she actually say this?
Have you listened to that podcast?
Moving on to the next article.
That's the second CFP Journal podcast.
All right.
Imitation is flattery.
That's true. I think we were first to market, and that's why we have the enormous listener numbers that we do.
Like and subscribe.
Yeah, why
That's
do they
what
keep
YouTubers
listening to
always
us?
say.
I don't know. Anyway, so...
Okay, let's get back to a learning point.
Supraventricular tachycardia.
Rand Goldman. I've never met him. Publishes a lot. Great articles.
He's in Vancouver.
Is he?
Yeah, he's at
Oh.
BC Children's Hospital. He publishes, my goodness, like an article or two in every CFP journal.
He
keeping
must
them
have a lot of
afloat.
residents to do all that work for him.
Yeah, like the two listed on this article. So what do we need to know about SVT in kids? What do those kids look like when they come to your clinic? Because they don't come in wearing a shirt that says, I've got SVT.
So what do these kids look like? So signs and symptoms in infants can be variable. They could have poor feeding, vomiting, irritability, increased sleepiness, fainting, perspiration. That's one that if a family member said to me and he starts sweating and sweating, that's one that's going to make me trigger myself to think about this.
As they get older, you're going to start to think about, the child who says, I've got, my chest hurts and I feel like my heart's thumping and I feel dizzy. And then how do the adolescents usually present?
So they come in with all those symptoms, and they may also have perspiration, fatigue, and anxiety. So it can be a bit challenging to tease all of them out, but just, you got to think, if these are sudden episodes, might be on, off, could this be SVT? What are you going to do then? What's the pharmacological therapy?
Well, I think we need to be very, very focused on the first thing we try before pharmacologic. In fact, I would say, let's be specific about this treatment.
Okay, so vagal maneuvers.
Don't
Did I
be
write
vague.
that on the... What?
Don't be vague.
Don't
It's
be
vagal
vagal.
maneuvers.
Don't be vagal. Did you
Don't
say
be
that?
vagal.
Oh,
That's right. Every month, a
are
better
you going to
dad
have
joke.
another child? That's a level 4 dad joke.
Very fantastic in dad jokes. And these are effective. Over 53% of the time, these are going to knock your patient out of SVT.
And this I love because they've got one with a diving reflex in infants.
Yeah.
And you're like, but then there's like always a caveat everywhere. They're like, but it's a bag of ice that you put on the because somewhere someone converted that SVT to asystole. It's
like immerse a child in
putting
water.
a child's head into water. Like, oh my
Yeah.
God, the SVT is gone.
So you
So
got
is
to put a bag
all.
of ice, but you got to make sure you don't
Anyway,
smother them.
Not over the nares, not over the mouth.
Exactly. Then you got other arrhythmias to worry about. Pharmacologic therapy. So yes, finally, let's talk about that. Of course, to break them out of IV adenosine, break them out of SVT, you want IV adenosine. And Paul, what kind of animal was used as the guinea
Yeah, this
pig?
I love. I know.
In this research.
A guinea pig. What sort of a guinea pig animal did they use?
was literally a guinea pig.
But no, but they used the first animal that they used. So it was from a bull's heart. Extracted adenosine from a bull's heart. I'd love to see that medical student summer project.
Yeah, but then they injected it into a guinea pig.
Into a guinea pig. Do you think that's the first time they use guinea pigs? No, it must be before.
Anyways, maybe we need a guinea
Interesting.
pig to try that on. So
But University of Cambridge medical student summer project. Take adenosine out of this bull's heart. Step 1, remove heart from bull.
back in 1929.
Yeah.
That's how we did the research. So you give a double syringe technique. Is that what you do, Paul, or do you have another?
I prefer in more rural areas single syringe technique. There's been a few articles about it. I've used this once, and it has worked. It's much cleaner
There
in
you
terms
go.
of getting the medication.
More convenient, half the cost
Yeah.
of syringes.
Yeah. Syringe lobby is gonna be
Oh,
pissed.
Just infuriating. The
They're pulling
asthma
back.
medicine lobby, the syringe lobby.
Yeah.
Just a sleeper there. You just slid that in there. Didn't even notice how clever that was.
Pulling
Well
back,
done.
yeah.
Dad jokes.
Sales
all
are gonna
around today.
plunge.
Oh
Or-
my gosh. Okay. So let's talk a little bit about what do you do next, or more specifically, there are situations in which you should not give adenosine. This sounds like an EM exam question, if you ask me.
Which is that? Oh, that's that second to last paragraph. So when can we do it? So I think there was 2 cases. So in patients with asthma, so we just talked about asthma, and in those with non-AV node dependent SVT.
Yeah, and they've always said, if they got lung disease, you should avoid giving adenosine, or if they're taking methylxanthine, because it can cause bronchospasm. But, people are going to get dyspnea based on their bronchoconstriction. Even though they've got normal airway function, the adenosine can cause bronchoconstriction. So patients are going to look like they've got dyspnea, even though it's not. It's related to the medication. So
Yeah, and then those non-AV node dependent SVTs, including atrial tachycardia, AFib, and atrial flutter. So they're not dependent on the AV node. So adenosine doesn't work on the underlying pathway.
It's so fitting that we went from asthma, a contraindication for adenosine, used for supraventricular tachycardia,
Yes.
because it can cause bronchoconstriction. And the next article is Bronchiolitis. Oh my goodness, it all just fits together.
ties. It's almost as if they. Do you think they thought about that and put that in order?
I guess we'll find out in our email from the editor, Sarah Fraser. She'll say, what, you think we don't put any thought into our content of our journals?
So what's the clinical question for this one? How can we as family physicians provide optimal management of bronchiolitis in infants while avoiding unnecessary treatments and investigations? That is a SAMP question written right there.
Oh my gosh, yeah. So optimal management is going to be trying to figure out, first of all, is this mild, moderate, or severe? And there's very specific criteria on those folks who got severe bronchiolitis. And obviously if they're in severe distress, they're lethargic, they're not feeding, they stop breathing, that's severe.
That's severe. But what about mild? The Happy Weezer. That was a band,
the
wasn't it?
non-spicy Weezer.
1990s. You look like a person who would listen to Weezer.
Weezer?
Is that do you know them or no?
I listened to Wheatus, just a teenage dirtbag.
Oh, I thought Weezer was a famous band.
Yeah, they had
maybe
lots of
someone out
different
there knows.
multicolored albums back in the day. So mild, they've got no distress.
Well hydrated, mucous membranes are moist, no or mild respiratory distress. So they're the Happy Weezer. So you hear them, but they're happy and smiling and playing around.
Yeah. And so right in the middle there, a little bit of respiratory distress, that's your moderate category. So how do we support these folks? And of course, when you're studying for your SAMs, you got to think about the non-pharmacologic options. And so I love this one because there's a long list of things we can do for these folks without touching pen to prescription pad.
Yeah, and the first one, suction. Any of these commercial devices to suck that snot out of the child's nose.
You're thinking
are these satisfying?
Your shop
used
vac,
them?
your Dyson, your...
Don't do that.
No?
No.
Hook it up to the... You don't do that for your kid?
I've seen that on Legal Medicine, not hacks at home.
Okay. So like the little tiny, like the nose... Oh, we can't use brand names. The non-brand specific nasal blue suction device sold at Whole Foods for like $45.
Ooh, I just
like
used a McDonald's straw.
Yeah, so there's no filter. Delicious.
Oh.
Why am I always sick when my kids get sick? No idea.
But it's satisfying. I know from real life experience, this can make such a difference.
Exactly. And so what else? Make sure their fluid intake is adequate, which, it's really neat working in Canada because we don't see those kids dying of severe dehydration as often as in other countries where that's...
They may not have those resources.
Exactly, and that's what the biggest morbidity and mortality comes from with some of these pediatric illnesses. Fever management, empowering families. How do you empower families, Paul?
I love recommendations that are so vague and all-encompassing.
You are empowered. Feel the power.
No, I think it's really giving clear instructions. These patients, the parents will be tired, they'll be exhausted. I've been that parent myself. Giving clear instructions on here's what you need to watch for and come back to care, because you don't want to have told someone like that, stay home, it's fine, it's just mild, without giving them the instructions about here's the things that we're looking for as physicians and when to bring them in. I'm always happy to see these patients. Give a bit of reassurance to their families.
And of course, most important, CNPAs always mentions in their lectures, follow up, arrange follow-up.
The interesting one for things not to do. Do not measure oxygen saturation if the patient appears well and has mild disease. In an ER context, it's almost a silly recommendation. Well, is this more just for are they specific to?
It's choosing wisely. They look good. They're happy wheezers. Don't put a SAT probe on them because it's just going to cause more stress. So look at your patient, not the numbers.
I think at triage that's going to happen. I think that's almost a dangerous recommendation to not be measuring routine oxygen saturation.
I think a third of the time
because it's going to be at the triage nursing level. I think that I don't know if that's a.
I think a third of the
what's
time,
their reference? 15.
Okay. Now you're going to do a deep dive here. What happens most often in some clinics?
They reference another choosing wisely in pediatric hospital medicine.
No, that's a competitor to choosing wisely.
Is it?
Choosing Wiley, as in Wiley Coyote.
So you should do it so carefully. There's choosing wisely, choosing unwisely, and choosing wily. Sneaky that. Professor. That answer they always have.
Do not order chest X-ray scans.
They published in the Journal of Hospital Medicine
in
2013.
You were just really obsessed with this, hey?
I just think it's interesting.
Can I finish my story? So the reason that most kids get the SAT probe measured is because the triage nurse says that we don't have a SAT probe for kids today, or the kid wouldn't keep it on because they're pulling it off or chewing on it.
Yeah.
So what else does choosing wisely say about here? Don't get an X-ray. Don't get routine blood work.
Do not order chest X-ray scans. Is scans needed in there? Chest X-ray scans?
I think it's one of the editing context for the CFP Journal. Every time they mention the word X-ray, they put the word scans next to it.
Oh, interesting. Chest X-ray scan.
Ask Sarah Fraser why they do that.
Huh.
For all those times she doesn't listen to her podcast.
If you're listening, she said she was, man. It was very nice of her to come and say hi.
Well, she'll never listen again after this one, that's for sure.
Happy Christmas.
Do not order routine blood work. But there is specific times. I like how it says do not order blood work
unless clinically indicated. Is there dehydration, a febrile young infant? But they're not going to be, because you're going to have hydrated them. You're going to manage their fever.
And then these kids with bronchiolitis, choosing wisely, what does it say about giving them Ventolin?
Nope.
Salbutamol.
Nope.
Corticosteroids.
Nope.
Epinephrine.
Inhaled or oral. So no salbutamol, no epi, no corticosteroids.
What about
do you see this happen in real life? I see
yeah.
it happen in the ER.
See it happen all the time.
Yeah.
Often before the MDs assess the patient, this gets given.
Oh, interesting.
triage.
Sometimes, triage.
Well-intentioned. I don't know if...
what about this? Do not order comprehensive respiratory viral testing.
Oh, parents love that, though.
They love it.
Get
Do you
the
want
swab.
to? Do you want to know what it is?
I know what it is. I just want to know.
I won't do this all the time, but I like to know what's circulating in my community. So when the season starts, I'll sometimes offer it and order this just to see what's going around. And sometimes I've had some kids who maybe look a little bit sicker. 3 viruses.
Okay, it's playing,
3 in 1.
Playing a little bit of amateur public health there. Aren't you? Yeah, just like you did all during the COVID outbreak.
Anybody.
But that's for another
Anybody
podcast.
can do public health.
That's for the podcast, like a band.
What?
Yeah, your amateur public health podcast.
Oh.
Just making you out to be an anti-vaxxer, which you're not. I should be full disclosure there. And do not prescribe antibiotics for bronchiolitis if you made it this
fair.
far.
That's fair.
I'm sure you're not doing that, are you, Sarah Fraser?
You're really pushing it, aren't you?
Really pushing it. Just like my patient with hypertriglyceridemia,
Ooh.
do they need a medication? And according to a lawsuit that I'm familiar with,
Oh, yeah?
they got really upset that the family doctor didn't suggest treating the hypertriglyceridemia.
So who's this? This is a young kid
This
with
is a young adult.
hypertriglyceridemia. Okay.
They had high triglycerides.
Yeah.
The family doctor did nothing. They ended up in the ICU with...
Did I ever tell you I had hypertriglyceridemia?
Oh, I didn't know that. Did you take a statin to reduce your
No,
triglycerides?
I actually took bacon.
Took bacon.
Yeah. So as a first-year resident, true story.
Okay.
Have I not told you this before?
Okay.
First-year resident, I went in and I had to get some blood work done. And we learned in residency you don't need to do fasting blood work for routine testing. This was for something else. It was for the military. So I'm like, I'm going to show them. So in Regina, they actually have like a 24-hour diner and bar next to Life Labs.
Oh, amazing.
So I went in at 8 o'clock. I ordered the bacon, sausage, eggs, ate that, and walked straight over as the lab opened for the first appointment so I could make it to clinic on time.
Beautiful.
Emergency call the next day. You need to start a statin now.
Amazing.
Right now. So that doc made the right call. I had to go in and explain that I literally ate bacon and sausages before blood work. You could see it like
So
emulsifying on the
you
top.
you played a publicly funded prank, is what you're saying. You committed a form of healthcare fraud, if you will.
Did not. It was $5.99 for the breakfast. That was it.
I'm pretty sure the Tommy Douglases of the world would see that quite differently.
That was his province as well. My God.
This is what happens when you get public healthcare.
Yeah.
People just throw it to the wind.
So in the end, I don't have hypertriglyceridemia, but the pig certainly did.
Fair enough. Okay. So if you suppose you'd gotten a statin,
Okay.
you would.
What's my
not-
risk? Is it gone?
You would not have gotten pancreatitis. That is the big risk we're trying to reduce. How much would that risk have been lowered? 100%? 99%?
80.
No, not even close. So it reduces your risk of pancreatitis by 0.1% with statins.
Wow.
And
can't believe
fibrates, no effect.
No effect. Okay.
Fibrates will lower your triglyceride level, but they don't lower your risk of getting
So it's
pancreatitis.
something, not nothing, but it's pretty close to nothing.
Amazing.
Wow. That's it
is
for a year. Incredible.
That's
And
the
look, they
end?
they can't do it alone. There's a thank you
Yeah.
right there.
Good volunteers.
197 volunteers who helped facilitate the fall 2023 CFPC exam.
And a lot
They had
big-
1,645 candidate examiner interactions. What does that mean?
That sounds expensive.
Why doesn't that equal with 329 SAMP written examinations?
And then the 600 oral
It
examiners
should be.
they
It
needed.
should be a multiple, shouldn't it?
Well, if you want to be,
Someone got extra SUs.
I guess so.
Maybe. Interesting. I'll have to do the math on that later.
And then a big, nice ad from the CFPC begging for examiners. So
There we are.
You too could become a CFPC examiner and be very familiar with what is on the SAMs if that is to your liking.
Here we are. That was it. What a great year.
That is a wrap for CFP Distilled December 2023, and that is a wrap for CFP Distilled 2023. And for those of you, special bonus shout out to those of you who just listened to our compilation episode of all 12 episodes packed into one amazing episode.
The only way you can get all the updates by listening to us and our horrible dad jokes. Next year, we promise to improve them from a 2 out of 10 to 3 out of 10.
On behalf of CFP Distilled, I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon.
See you next year.